Stop Okay, good. So just a few quick announcements. At your tables, you have these forms. If you could just take a moment, as Dr. Prasowski gets himself up over here, we have a few more seconds. If you could fill this out. We need your evaluations, and the faculty will go through all of this, so it's really important, please. And as far as departures, whoever's taking Midway or is flights, whoever has flights out of Midway, you just take an Uber from the lobby, and that's in the front. Everybody else who is going to O'Hare, when you walk out over here, you'll make a left, Illinois Street, and they will have a big bus ready like around 11:15. As soon as the course ends, there'll be a big bus to take everybody to the airport. If you have later flights, then just take an Uber on your own and you can expense the receipts. So anything from Uber can be expensed, either coming in over here or leaving, and back and forth to the course. So fill those out. Okay, cool. Dr. P's here. Yes, hi Dr. P, good.
Same, I could talk of the three of us. Although George and I, we're fellow mates. Kenny was a couple years behind us, but I remember when George was going off to start his own show, and I I had itchy sand in my shoes to get started right away. So I was offered a job in a place with a lab that was already up and running, and I thought, that's great, I'm gonna take that. But George made the better decision. He built his own program. It's not like, you have a cruddy career because you didn't, but it's just different. So it's one of the things we were talking about at my table upstairs is how to make that first move. Think about what you want to do in life. Be happy, right, George? I mean, you got to go to a place you like. I mean, George went back home, basically, he built a career. Ken, same. Yeah, I went to Indiana. I mean, I certainly had a decent career, but, I'm not an Indiana guy. Basketball or politics or probably most of the other things. I'm a New York guy. But so first move you make is an important one, and it shouldn't be just career. You got to look at how you're going to live and who you want to be with and how you want to, it's not, if you're good, you can be good anywhere. I mean, it's kind of like Frank Sinatra, right? If you can make it in New York, you can make it anywhere. But seriously, no, if you're good, if you've got good protoplasm, you can make it anywhere. And you don't have to say, oh, I have to go to blah, 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 because they're going to offer me $12 more. Go where you'll be happy. Anyway, I'll leave you with that thought. All right. So, George, you want to start maybe? Take the first tranche here? What do you think?
Sure. No, I'm very happy to do that.
I kind of had you going. I had this actually 30 minutes because we're going to probably end a little earlier so people can make flights and stuff. So George, give us each 30 minutes and we'll be really good about it. When 30's up, we'll go on to the next person. We'll blast through till we can get done today, get people out of here. So how about just do it, in 30 minutes, George, whatever you get done, you get done. We did a couple ways yesterday. We did it walking around, coming to the board. You like just doing it from your seats today? You want to come to the board? You don't care? You come to the board twice. You're going to tell us what we're going to do today. Well, you rather come to the board or sit and chill? You don't care. Doesn't care. That's not a good answer. I don't care. Chill. How about that? We'll take it from the seats. George, what do you think? Because it's hard for you. You can't mentor at the board anyway. So how about for George's section, we'll let you go tables and somebody will opine and we'll point things out. All right. Up to you, George.
Okay, guys, let's have a look at this one. And when you're looking at it, I want you to think strategy, overview, and frame your problem. And usually, when you're looking at, basically it's an SVT, right? So what's the name of the game in particular when you're looking at an SVT? It's a P-wave search exercise, okay? So go for it, all right? So we'll just give you a few minutes, wake up,
What's this, a new one? No.
What's the best league to look for P-waves?
Pages? Seriously?
Do you want me to do presentation?
Yeah, if you don't mind, the online thing.
Oh, sorry, okay.
Thank you.
What's the best lead to look for P-waves? The answer is any of them could be the best lead. Huh? The usual productive ones are 2 and a V1, all right? But you want to look at all of them, all right? Sometimes it's ABR, who knows? P-search, okay? P-search exercise.
Yes.
Okay, we have 11 answers. I need 20 and then we'll talk, okay?
By Gemini? What am I missing? Oh, God, seriously?
Okay, let's see the results of that. And we have option C. Okay. Does anybody want to discuss it? Any table want to discuss it? It's not rocket science. What is your... Okay, go ahead. Go for it.
Hey, good morning. Yeah, we so we looked at it and we realized, this is a narrow complex tachycardic rhythm with some areas that seem regular and other areas with variable cycle length. When we were looking for sort of candidate P waves, looking at the rhythm strip, towards the end of the rhythm strip, we see an area where there looks like there's several non-conducted atrial depolarizations. And so I think the whole table here measured the cycle length there and work backwards to see, hey, can we march this out, and are we convinced that this might be the mechanism for?
That's just outstanding, all right? So, and it's not rocket science, is it, guys, all right? It's having a strategy and knowing what you look for. I look at a tracing like this, the first thing I do is boot up my calipers. And then what you did was you were looking for, I call it a hole, all right? This is a hole where you actually see things a little bit. So you see the hole where you see PVCs or something, or just get a long enough strip, you see a hole. And when you see a hole, things become obvious. Huh? And when you do that, you can come over here and, well, you can just, if I take V1, I have two of them that I can hang my hat on, and I go like this. I see where the next guy falls and falls over here, okay? And then I can walk through and see, well, that guy sits here and this guy sits here. So now you actually see every bump, right? Except the ones that are fortuitously right in the middle, but they all deform the QRS a little bit, all right? And you can walk them through. And you pointed out that, and you did this, and this is my slide, and you pointed out something to me, that the easiest place to look at it is right here. You got a big hole. And you observe that when you made your general observations. So I'm looking at it and I say, it's an SVT. I got to find some P waves. It sort of looks regular, but a little irregular. What the hell's going on? And I look at it, and then you saw the hole, and you jumped in, and it was obvious. You put your calipers in there, and that, if you make the timing, you actually see 4 of them in a row, all right? And you can walk them right through to the end with the calipers. So this atrial flutter, all right? And you want to look at it superficially, it's got a little bit of an R prime, huh? Maybe it's AVNRT, could be AVNRT, a little wobble in the AH, huh? But that's a flutter, okay? This is a good one. And you have your usual suspect. Yeah, go ahead. Sorry. We're just hanging on a second until she brings you the mic. You don't want to get Cindy have a heart attack or anything running over to you, so just wait.
So for the prior ECG,
are we going back to the prior one?
Yes.
Okay.
So the P waves are obvious on V1, but my vote was for AF with AFib with organization into V1 over the Bachman bundle, because you don't see the P waves anywhere else.
Forget about Bachman's bundle. This is just ECG, and we're not talking mechanism. Our focus is to find the P wave. For as far as mechanism goes, who the hell knows what the mechanism is? Usually, macro reentry, right? But it could be focal, could be automatic. We don't know the mechanism. So if you get into Bachman's bundle, you're going somewhere where beyond the ECG. You want to report the ECG, and for clinical purposes, it's flutter. And it's not really fib, because you can walk right through. You nail these guys and walk right through.
But none of the other leads, though.
None of the other leads? Well, that's because the P wave is flat. You have to pick. I'm missing your question. I apologize.
So I'm trying to say, this is probably a left-sided AFib that organizes over the Bachman's bundle, and then on V1, which captures the only right-sided lead, you see.
That's a pretty hairy call. I don't know if you can make that call.
Well, you may well be right. I mean, but you see,
it's hard to tell, though, right?
Keep it simple. Maybe you're too smart, huh? You got to keep it simple. Clinically, this is what it is. It is what it is. You see the 4, 5, or 6 in a row. You can walk right through. So it's a rapid atrial tachycardia. It's a rapid atrial tachycardia, which by our usual definition, namely heart rate of 250, is flutter. We call it flutter arbitrarily. It's really an atrial tachycardia. What the mechanism of that atrial tachycardia is, that's another story. All right.
And just from a very practical viewpoint, if it's flutter, if it's fib, they're handled identically clinically. anticoagulation approach. I mean, unless you're in the lab, right? So you're making an hypothesis that can't be proved by this tracing.
That's what I was trying to tell him.
Yeah, that's all George is saying, that we're not saying you're wrong, it's just prove it to us. I mean, there's no clear fib on the left side, right? There's an irregular rhythm, and he's showing on the right side there's a bit of an irregular rhythm too, and it's P wave. So we're not saying you're wrong, we're just saying you can't prove it.
You're going beyond the scope of what this tells you. Now, I think it's fair to say, and I'll ask Ken this, if you were going to book this fellow for ablation, whoever this is, would you be planning for a tricuspid isthmus, or would you be planning for a PVA?
2. I plan 2.
Well, tell them why.
Oh, well, me personally, if I see somebody in the office, I'm sending him down just to let my team know. I'll say, look, I think the person has flutter. Fib obviously caused the flutter, and I can't be positive there wasn't fib and flutter there at the beginning. So please, when you take to the lab, take out the pulmonary veins and then go to the right side and do a flutter line. That's what I tell them. That's the practical approach. I just do both.
It's more than practical, it's mechanistic too.
Yeah, and mechanistic, right.
Ken?
Flutter is rarely an isolated arrhythmia. I mean, occasionally we'll do a flutter ablation only in a very elderly patient, just because this is another practical aspect. Patients with atrial flutter generally have much more rapid rates because they have less concealed conduction to the AV node. They're much harder to medically manage, but there is a lot of data that suggests that maybe you don't even need to do the flutter. Maybe you just need to do the PVI. If you do such a great job, if we were able to do such a great job with PVIs, probably wouldn't need to do a lot of flutter lines.
I think, yeah, if you had durable PVIs,
Yeah.
probably most of the patients wouldn't have flutter. Actually, Andrea Natali published that years ago in a study. Small study, but he did publish it. But the point is, I agree with Ken. Sometimes it's just hard to handle flutter medically. It's just hard to handle it. And sometimes, especially an elderly patient, it's like almost no complications to do a right-sided CTI. You get in, you get out, and you know you're gonna have fib to deal with, but fib is not so hard to deal with as a clinical problem. So you just gotta use it's called seichel, it's a Yiddish word, like, common sense. A little common sense.
Well, common
You
sense.
seem to be, look at his face. George, he's still bothered by this. Would you be happy if we tell you this is fib on the left and then organized into flutter on the right? We'll give you that. How's that? I just want you to feel good.
I'll take it.
Okay, we'll give it to you. For the rest of you, we don't know.
So look,
We're gonna give it to you.
here's when I do a flutter only, tricuspid isthmus. I want to see typical flutter, and I want to see it repetitively. So I want to look through the patient's records, and every time they present or they've been seen in tachycardia, it's typical flutter. Then I'll do just a flutter line. And to be quite honest with you, I mean, I don't knock our healthcare system. It's got a lot of good advantages that yours doesn't. But on the other hand, we do have about 10 months wait list for a PVA at our place. We've only got a couple of labs. And so that if I think that I can get away with a tricuspid line, we can do that almost right away because it's only an hour slot, okay? So just from a practice, if I see typical flutter repeatedly, I think that's not an unreasonable indication to just do a flutter line. When you see something like this, it's not a typical flutter. It's not the nice sawtooth. It's pretty rapid. And the more rapid it is, the more likely it is to be some sort of a focal left atrial tachycardia, all right? So this patient would definitely be booked for both.
Yeah, and just one last thing. I know we're getting off base, but that's okay. These are practical things for you when you see patients. I have a slide I made up, George, because it's hard to explain to patients the fib causes the flutter. So I made up a slide that shows the comparison of an automobile and a circuit. So I have them, you know how you start a car, you push the button, and then the motor starts, right? So on the other side of the slide, I hand this out to the patients. I have a fib focus starting a flutter, and I tell them that while we've only seen flutter, you have to understand something has to start it. Just like starting a car and then the motor goes, the fib starts to flutter, but the fib could be 6 seconds, 8 seconds. It may never be a clinical problem. So George's approach is uber practical because if you've seen mostly flutter, the fib may be 4 minutes, 5 minutes. You just need enough to start the car. You don't hold the thing in for 12 minutes. You push it, you start the car, and then you go, right? Well, that could be fib. So you don't know until you get rid of the flutter if it's a real clinical problem. You know it's going to be there, but you don't know if it's going to be a clinical problem. So that's just a practical point. If you, like George is saying, if you keep seeing flutter, it's dumb to tell the patient we're going to cure you because you know damn well there's fib in the background. So I always tell them, we're going to get rid of this problem, but just hang in there. We don't know that you have another problem. Don't promise them a rose garden when you don't know you got one. So that's all.
When I spent some time in Bordeaux years ago, Pierre Jaïs used to say that the atria play ping pong with each other. Huh? So
That's
the
good.
fib
I like that.
begets flutter, it gets the flutter going, and then it turns into flutter, and then the flutter will get the PVA rolled up again. So like Eric's point, but Jaïs used to call it ping pong. The other thing is our patients don't usually need explanations like that. We just say, don't worry, buddy, we'll fix it. It'll be okay. I learned that in France, huh? You know, just do the damn thing and get on with it. The French don't ask questions when you, Americans are funny like that, huh?
I'm not going to answer. If we start to talk about treatment of fib and flutter, this is a question. We're never going to get more than one E-gram ourselves.
All right,
so,
go for this. Go for it, guys.
I can't do it.
Go for it. This is a very good one, all right? It's very instructive. So I'm glad we were able to get to it. So give it a go. I want to see 20 people, then we'll talk. We'll anoint the anointed, whoever. It's pretty good for Sunday morning with a bunch of hungover people here. That's good. Those compliance people have to see that we're actually working in Chicago on Sunday morning. Yeah.
Well, we're sitting up here. We haven't yet to determine if we're actually working.
Yeah.
Think strategy. Think strategy. Think where you're going to find the answers.
I don't have a straight. I can't. Oh, they do. George, you want it?
I'm waiting for 20, and I just got it, so.
Oh, 20 is your magic
I'm waiting
number?
for. All right, guys. Does anybody want to discuss this? And I must say, guys, I feel for you because this is like quick chess, huh? And it's hard. It's really hard to do this. You know, usually, and I'll make a confession to you, if I have a tough case, I'll sit down, put my feet up, throw it up on my big screen and say, okay, I'm going to do a crossword puzzle and relax. And if somebody said to me, all right, what is it? Then I end up saying something dumb. So I do appreciate that this is a difficult exercise, all right? That notwithstanding, do we have a table that volunteers to tell us what is
Carolina, up to you.
what is your strategy? You don't have to come up. You can do whatever you
No,
like.
she is really conflicted, this young lady. I'll tell you
Why is this?
Because she's UNC through and through, but she's wearing Duke-colored pants. She's really, because I think she did that for me, because she knew how happy I was Duke won last night, you know?
I will say though, you're wearing powder blue as well.
And I'm wearing Carolina blue
Kind of
shirt,
the Carolina
unfortunately.
side.
So I screwed up too.
I must
Be a
say,
great weekend.
I'm always amazed how America goes nuts over college basketball. I mean, I like watching college basketball, but Eric takes it to.
I go to Vegas every year. I'm debating going down to New Orleans.
Is
Wow.
I
everyone's
got a call
phone.
last night from a friend. He said, I got tickets if you want to come down and I'm going to hold the seat for you.
See,
So I'm
while we're
toying with the
bullshitting, you have more
idea.
time to think, huh?
On March Madness, there's a reason.
Yeah, there's a reason it's called March Madness. Well, you in hockey, come on, you love hockey.
Actually, I've grown to like baseball better in my old age, huh?
Yeah, baseball's fine as
Sit
you
and
get
bullshit
older.
with your friends, and you don't miss any action if you turn away,
Right. Well, it's because
beer.
because they get 3 pitchers to come in for 1 batter. That's the problem these days. Isn't like Sandy.
Baseball is really, it's a beautiful,
It's not like Sandy Koufax years.
it's
you
a
know?
beautiful game. All right, go ahead, tell us.
Okay. So where I started with this tracing is I started by measuring the R to R interval and our sinus speed at the end.
Okay, and what has she done that's really good?
Oh, yes.
She's looked at the easy part of the tracing and made some observations on the easy part of the tracing. Sinus, there's no pre-excitation. That's helpful, all right? Which sort of makes the pre-excited option even less likely than it was originally. So that's good.
I then took that interval and compared it back, and I saw that the interval with our wider complex tachycardia to that beat is longer, suggesting some sort of potentially a pause between, or the transition between it resuming it going to sinus rhythm.
Okay, so there's no particular reason for aberrancy is what you're saying, is that right?
Yes, sir.
If you just look at this wide part, what do you think most people will call it if you gave it to your average medical resident and you're supervising or something? What do you think they're going to call that?
I think that I would say it looks like a left bundle of morphology.
No, forget about the morphology now. I mean, it is 1, 2, and 3, and that's probably close to being right. But what strikes you about that rhythm is it? I don't want to read my mind, but anybody else reading my mind? I mean, it's totally irregular, right?
The irregularity.
I mean,
of it.
I can just tell you, the average trainee will call that atrial fib. In fact, most of our cardiologists would call it atrial fib, all right? Because it's so irregular.
Yes.
But you know that does not dissuade you from VT, does it? I mean, so this audience knows that the regularity does not help you because it could well be VT with that irregularity, okay? And now you're trying to look at morphology, which is somewhat helpful, although less helpful when you've only got something like 1, 2, 3. It is probably 1, 2, and 3, but you don't know that, all right? And what are you going to say?
I was going to say, I somewhat thinking through a possible morphology that just the notching on our downstroke, the widened complex, potentially fitting
Looks
that
sort of like a
morphology.
VT morphology is what you're saying.
Yes, sir.
It does not look like a nice aberrancy pattern,
I didn't.
all right? It's sort of, if anything, right bundle, left axis, all right? All right, so that's good. So far you're thinking VT in spite of the irregularity because of the morphology. And if it's a VT, it's sort of right bundle, left axis, but the right bundle seems to come and go a little bit. What's this guy here? Is that a P wave? Is that, I remind you of the mud that I fell into with Ken's slide. Is that a P wave? Yes, no? And why not?
I don't think
What did Ken teach us? Yeah,
that
be very aware of things that are within the QRS. And if I'm looking at my calipers, I try to do what I call defining the limits of the
Yes.
QRS. So I've lined up the end of the QRS here, 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 and I see that this guy falls within the QRS boundary. So any ditzel within the QRS boundary, you can't use it, okay? So there is no P wave that you see really, all right? You see maybe a pseudo P wave at the end of the QRS. It's irregular, right bundle, left axis, or just left axis, no bundle, all right? Now you're going to get to the smoking gun. All right, now where do you think the smoking gun is? Anybody can come to her aid if you wish. What did we say about the most valuable part of the tracing?
I think the onset of the
Onset. So
potentially-
how does it onset?
It looks like certainly a change in access. I think a change in our initial.
No. So first of all, if you think that this is the first beat of the tachycardia, then you are comparing this wave, this one, to that one. And you might think, is there a P in there? all right? And that might be instinctively okay, but then you look a little closer at
Yeah.
this guy, and what do you see?
I wondered if that is potentially a fusion beat between what is our next wide complex tachycardia and then the sinus beat preceding it.
Excellent, excellent.
That's a great call.
You noticed that the PR interval shortens, all right? PR intervals don't shorten like that in the middle of nothing, all right? So that's fused. And not only that, but why is this T wave so big all of a sudden? It's not a P, it's a T, and it's fused. See, the dipole fuses, but the repole also fuses. So now this guy, you're seeing partly sinus, but the beginning of it is the VT, and the repole is VT-ish, halfway between this and this. Big repole, okay? So this is VT. And there is, I don't know if this is general knowledge or not, but when I see right bundle, left axis VT in someone who is overtly well, it's usually an idiopathic LVVT, like a Bell-Hassan type, because that involves AV nodal-like tissue in the Purkinje system, his Purkinje system. Again, the Japanese have done a great job of showing us the mechanism of that and the fact that it is AV nodal-like tissue in there, and that could look like atrial fib. And the usual thing is that often these people are asymptomatic, and it's benign, all right? So this patient, if you have no heart disease, and Eric might look at the 12 lead, the ECG during sinus rhythm and say, well, that doesn't look like an abnormal ECG in particular. The leads I have available look pretty good, all right? So this is an idiopathic LVVT, so-called Bell-Hassan type, after the Israeli guy who first described it. And it's a verapamil sensitive VT, by the way, diltiazem sensitive VT. It's, but the major teaching point is not the mechanism, but that you nailed the VT, okay? And the teaching points are, it's a wide QRS tachycardia, you did really well. You started with the normal part, you got the low-hanging fruit, you made a few conclusions, and you made the general observations, and you went right to the beginning. And the beginning is where the answer was. So it's a very nice tracing. So it's the game plan that counts, all right? Not just jumping in and going it from left to right. When I used to teach with Wellens, you know, I don't know if you guys are the same, but Wellens would start from the left. He'd start from the left and work his way across. And you could not, like I was trying to, when I did sessions that I was trying to orchestrate and chair, you know, like Eric knows as well. And I would say, Hein, you think right at that the second line there, that looks like there's some good data there that might get him started off. No, he went right. I mean, you don't argue with the professor. I mean,
Yeah.
the truth is that Wellens was doing great things when I couldn't find a toilet yet at Duke. So I referred him. He's a great teacher, but he was very dogmatic.
Methodical, dogmatic, you do it my way, but he was almost always right, but you didn't deviate from the plan.
He didn't deviate from the plan. And because he's so smart and knows what he's looking at, doesn't mean I can help you. You see, the reason I'm helpful to you is because I'm a dumbass myself. I need a plan. You know, I need to work it out. You know, I don't just look at it and say, like, Jackman is a hell of a smart guy.
He's all over the board, though.
But he's
like a shotgun.
I love Sonny. He's just a smart guy. He's taught us so much. But then when I'm trying to learn from him something, he's too smart for me, you know. He's too complicated.
He goes, oh, look at that little thing over there, you know. And he was my fellow, believe me. I've known Sonny from a long time.
He's a great guy, Sonny.
Yeah, but
Smart
he's so different than Hein. But so George, I don't know, do we have enough time for another one, or do you want to switch it to Ken?
That's up to you, man.
Well, I'm just trying to keep us on time today because I'm worried about playing in things for
Let's take him, this one is the last 2 seconds.
Quickie, can you do it in like several minutes, you think?
Absolutely.
Okay, go ahead.
We'll give him a couple minutes because, not to put pressure on you guys, but it's a bit of a layup.
You know, Wellens was a hell of an electrocardiographer.
He's
way
fantastic.
beyond in the he wrote some wonderful
Yeah,
ECG
and even
stuff.
Mark Josephson, you know, he was a smart guy. He was often right, but he would just see it, and I would have to sort of go through A, B, and C before I saw it. He just nailed it.
I learned something. I learned so much ECG stuff from Hein. I mean,
Yeah.
you know, he just really knew how to work through an ECG. He has even has a sign named after him, right? The Wellen sign, one of those MI crappy things.
Yeah, I know.
Yeah, I mean, he's really a smart fellow. Come on, you got to do this quickly. What's the matter with you all? He told you it was a setup. Yeah.
Quick chess. Okay, let's have a look at the results, guys. Option A. Ooh. So much for it being easy, huh? Okay. I need a volunteer table. It's easier to ask for a volunteer table rather than a volunteer because you split between, you can all sort of look at each other.
And you have to do it quickly or someone's not going to make a plane.
All right, so I wasn't 100% sure afterwards.
Where's the
after I
voice coming from?
submitted
Over there? Oh, thanks.
After I submitted my answer. So I realized afterwards that there was a stem. And then afterwards, I looked at the rhythm strip at the bottom. But
Does this stem help you?
it changes the probabilities. But when you look at purely the tracing, I did not think so.
No, that was a real stem, by the way. If I say something specific like that, actually, that's real. I didn't make it up. But in this case, it's not helpful, as you say. Okay.
Yeah. So, I mean, look.
Where do you start looking at the tracing? Where are you?
I started on the left.
Good.
Just because it's abnormal and, you know, one of my mentors says measure everything. So I went PR. You know, you have a baseline bundle branch block, probably, I think looks like a left bundle.
Absolutely.
So baseline left bundle, normal PR. You walk through the first 3 PRs are normal, and then you have a premature. And it looks like there's a PAC in the T wave. And then
Exactly.
afterwards,
Go ahead.
afterwards, you know, there's some possibly a funny deflection in the T wave, or that's just the baseline T wave from the bundle.
Which
and
one? Which T were you looking at? The one I'm pointing to, or this one?
The prior one right there.
This one?
Yeah.
Yeah,
I think that's
it's-
just the.
Maybe.
I think that's just the baseline.
Maybe,
T
but I
wave.
think, but if you look at the repool here, it doesn't look that dissimilar from the repool
Yeah,
there.
exactly.
So probably that's not a P wave, but it doesn't matter. So you're using Wellens, you're going from left to right, but it's also compatible with the way I look at it because you started with the easy part of the tracing.
Exactly.
And make your conclusions. And you've already looked at this. And what are you going to do next?
So, I mean, the next beat, the one that you were pointing to, that looks like a PAC
Right.
that initiates that beat. Because the P wave morphology is different. The sinus is wider than what initiates that QRS. And then there's the change in the T wave there as well. And kind of moving forward, I just looked at the QRS morphology. It looks very similar to your baseline bundle branch block. And that to me was the biggest clue that, you know, are there A's driving the V's? And I thought there were. Hard to tell because the QRS is so wide. But I thought I could find P waves in front of each QRS, especially.
Where is the P wave now? Stop me when I'm walking across. Where do you see the P wave?
Right about there.
Right there. Can you prove to me that's a P wave?
I cannot. But
Yes, you can.
Oh.
What's over here?
It's a smooth.
Smooth. What's over
ST
here?
segment.
Smooth. What's
Yeah.
over here?
Not smooth.
Bump.
Yeah.
And not only that, but if this is lead 2 and 3, what's the vector?
Negative.
Low to high. All right. Now, it's not inconceivable that that's bundle branch reentry, but Ken, how often do you see good retrograde conduction like that with bundle branch reentry?
It is inconceivable to me that this is actually bundle branch reentry. If I look at that first beat that has 133,
Yep,
this beat to the left,
this
that
one,
beat, the PR interval is absolutely less than the PR interval to the left.
this one,
Measure it on channel 3. Measure the PR interval.
this.
Huh?
You think that that's different than that?
I do.
This PR interval? Yeah, maybe, but then the P wave might be coming from, that might not be a sinus P wave, huh?
Could be.
Yeah, I think the critical part is you've got another P there, all right? And now it's over 200 milliseconds there. So that's conceivably a slow pathway, all right?
Yeah,
And-
I agree with you though, as far as bundle branch reentry. Typically, they do not go to the atrium. I mean, I'm sure,
Yeah,
I mean,
very
the
rare.
vast majority of them do not go to the atrium.
Especially quick like that,
Yeah,
fast pathway.
so I would have thought you were showing some kind of, AV node reentry or something like that. I didn't think it was going to be a bundle branch
Exactly,
reentry.
exactly. It's just AV node reentry. And the clue, the exercise here is, you look at this wide QRS tachycardia, and you look at it, and it's about the same. And it's a little faster, so you might expect it to be a little different. And you're comparing this guy to this guy, because you got a P wave candidate, right? And you want to check out whether that's a P wave candidate. So now you're moving over here, and you see that's a P wave. That's got to be a P wave, all right? So it's more than the P wave candidate. So of your options, it begins with atrial activity. It's not going to be JT. I mean, theoretically, it could be JT, okay? But it's not going to start like that with a P wave over a slow pathway. AT, not really, because the VA, once it's linked there, is the fast, slow pathway linked, all right? It's not a AT onset, all right? So it'd be not inconceivable, but it's very unlikely. It's not bundle branch reentry VT, all right? So for a board type of strategy, your problem is framed for you, but before you answer the board question, you have to know what the hell's going on, all right? So I want to emphasize to you the methodology, the simplistic methodology for looking at it. You're looking for P waves, and you see these two complexes, and the critical part is comparing those, all right?
Super.
And if you remember these little simple things, you will have no trouble with the great majority of stuff they stick in your face, all right? Okay, Eric, that's me in the middle, guys.
Which one am I there? Am I the
Well,
guy in the middle or the
no,
left or the right?
No, that's you, and that's Ken.
You always love the Three Stooges.
I love the
give you
Three
that.
Stooges.
I knew you loved the Three Stooges. All right.
A buffoon from way back.
You could have put the Three Amigos up there. You could have modernized it a little bit. All right, so Ken's going to do a couple, and then I'll do a couple. The thing is, we want to get to your tracing, so we want to leave enough time to get to your tracings.
So I'll just do two quick cases. This is a 63-year-old woman with a history of paroxysmal AFib, aortic stenosis, and she has a mechanical valve put in. And then she has a 3-day history of palpitations and shortness of breath, and they call an EP consult. And this is her electrocardiogram.
ECG set, or
I don't know if it is, so.
you don't think it's there?
So this is, okay. Okay,
Right after 35?
so this is the 12 lead EKG. What do you all think?
Take a table. Want to have a table opine? Pick a table.
Well, just, let's take this.
Stick with, yeah, I was going to say, as you find a table, stick with the rules like George just told you, Look, what is one of your rules, George? Look for the break.
If it looks like a duck and quacks like a duck, it's usually a duck.
Yeah.
Low-hanging fruit, when you have a 12 lead, is the morphology, all right?
Right, but also your idea of look for the break,
Yeah,
right?
look for the hole.
Look for the hole, look for the hole.
So we have a wide complex tachycardia with a left bundloid morphology. And at first glance, it looks a little bit irregular, so I'm still wanting to march it out, but I see a break after the
Can you tell me
seventh.
before you see the break, is this typical or atypical? Just forget about the break. From a morphology point of view, would this be a good left bundle? Look at V1, 2, 3. Little tiny R,
it's
very
typical.
steep down. Pretty typical, pretty respectable morphology. So it's not, it doesn't mean it's not VT, but it's not particularly, it's not a VT morphology. All right?
And then when I look in the break there and look at the rhythm strip in V1, I see a good candidate P wave there.
Right here, right?
Yes.
Okay.
Which makes me think it's an atrial rhythm.
So some sort of atrial tachycardia, post-op.
Why do you think it's an atrial rhythm?
Because I see a P wave in that break right before the next QRS.
Right, because the tachycardia after a pause starts up
With a P wave.
with atrial activity.
No, I think it's a continuous tachycardia.
It is
Just
continuous.
changes
but-
a little bit, organizes. And then I'm going to show you the 12-lead EKG 24 hours later. What does this look? What? Pretty normal, huh?
Sinus rhythm with a normal width QRS.
Okay. And now 12-lead EKG 48 hours later. What's going on here?
Sinus rhythm with a left bundle branch block.
And probably atrial bigeminy. So why am I showing you this? Because this patient has a tachycardia-induced left bundle and a bradycardia-induced left bundle, and that's really, really rare. In fact, Mark Josephson says, although tachycardia-dependent block can be right bundle or left bundle, most of the time it's right bundle. Bradycardia-dependent block is always manifest as left bundle. So in this one patient within 48 hours, he had in sinus rhythm, a normal EKG. He had with tachycardia, a left bundle branch block. And this is just sort of a diagram showing that. And then he had a bradycardia dependent left bundle branch block. So just sort of an unusual EKG, sort of cool.
So I have a question.
Cool physiology is what it is.
Yeah, no, it's very cool. The thing that I find most fascinating is what you're calling atrial bigeminy.
Go back to the 12 lead show.
I think it's very cool.
48 hours later.
Yeah, can I take, yeah, this is the one that I find, do you really think that's atrial bigeminy
Well, I think we had some other strips
to prove that?
to
Could-
prove
'cause
that.
couldn't
This
it
could just be sinus Brady.
Yeah, I
Yeah.
was wondering. I wasn't sure if I.
Can we ask one of the candidates to discuss that? Because it's more of a, I think it's a universal thing rather than your issue. I thought about it too. You were calling that second P wave. Let's look at lead 3, let's say. Why is that a P wave for sure? Like Ken says it is, but why are you confident about that? Why is that a good P wave candidate? Because you've taken the QRS boundary, you've drawn a straight line at the end of the QRS in all the leads, and you see that that's outside of the boundary. Not only that, but it looks similar to the other guy. So is it a high to low or low to high?
High to low.
High to low. So it's not going to be an echo, right? An AV nodal echo or something. So you can take it to the bank that's as Ken assured us, that it was an atrial bigeminal
Well,
rhythm.
or
Yes.
just part of repolarization. So I mean, I'm just doing probabilistic. You know how
Okay.
uncommon it is to get atrial bigeminy, especially with that coupling interval? That's a 400 millisecond coupling interval.
Good point. Good point.
So
Except
I
it's
just
a-
don't
it's a
know.
little
I mean,
sharp.
yeah, I mean, I just don't know. And Ken says they had longer strips where it came obvious. That's what I would ask for. I'd like to see a little more information. I mean, I'm buying atrial bigeminy, it certainly, but I think it could also be T-wave repolarization until you show me a longer strip.
Absolutely, but If you look at this, Eric, if you look at V1,
Yeah.
what's the QT? The QT is about 400 milliseconds, two big squares. And you know, you don't usually see a sharp guy like that in the middle of the
Right, but
report.
you almost never see a P wave that early, and it's not conducted. I mean, it's a pretty damn early P wave.
Well, it's 400 milliseconds.
Right. So 400 milliseconds atrial bigeminy, and none of them ever conduct. Why isn't he conducting?
Okay, so audience will have to concede to Dr. Prostowski that yes, it's not for sure a P wave. I think it's highly probable. But,
I think
but
so.
I agree with him.
But I guess what I'm saying is, if we were in our board review planning the EP boards, the three of us who were on the committee together, this question, when George was chair and when I was chair, would be thrown out, because we would have this argument. And without more information, right, George, you can't prove it. And on a test, you have to be able to stand by your answer.
So you'd have to show a backup tracing.
Yeah, so when Ken says he was just whispered in my ear, we had other tracings, I mean, then that's it. It's an atrial bigeminy. I'm not going to deny that. But if I was just showing this, and somebody said, what do you think it is, Eric? I'd say it could be atrial bigeminy, could be just a funny repole.
Absolutely.
And I'm not sure.
What would you want to see to convince yourself that it was atrial? You're looking at this, but what would you want to see? Anybody?
You'd want to see sinus rhythm without that.
You'd want to see some
P-wave
sinus
in-
beats without that. And if he says he has that in the backup, then that would
Then that answers the question. Yeah, but I didn't see that yet, though.
Does it
You
help
didn't
at all
show
to
us that. Yeah, I'm
compare
sorry,
the
what?
does it help at all to compare the T-wave morphology on this strip to the one with the patient is fast with a left bundle branch block?
We can go back to
Oh,
that.
look at it.
That is a hell of a good point.
That's a
it
good
looks-
thought. Let's go back.
Kudos to whoever said that. I didn't see, but whoever.
Dookie, our Dookie.
That's great. That's fantastic.
There it is.
That's the answer.
The one before that.
No, the big left bundle.
No, well, that one there.
This is the one you want to look at.
Yeah, that's the one you want to look at. Look at V1.
Yeah.
Look at the repole in
That's
V1.
the left bundle?
No, this is normal.
This is
wait.
normal.
Oh, what was the one, the last one? Maybe I was just missing.
Now,
That's a left
now it's
bundle.
still- is that the left bundle?
That's
Yeah,
the left
okay.
bundle. You want to
All
see
right,
the
you
left
wanna see the
bundle.
left
We
bundle.
went
All right.
two ago.
Go
Go
ahead.
back two.
Go ahead.
Well, who the hell knows?
Right. Well,
I don't know. It's too fast for me.
No, I know, but it's still
I'll buy
fast,
what
but it's
Ken
still a
said.
nice smooth repole, isn't it? I mean,
can we get the next case, please?
Yeah, because we're trying to, we don't want to go too far in the mud. Listen, trust me, if he tells me he's got further proof, I'm fine. You know, but just cold given to me, I think there's a differential.
So this is a patient who had multi-valve replacement, okay? And we're called to see the patient because of this rhythm.
Ken, you know, again, I've got 38 and then it moves to 41.
Yeah, sorry. They're all
Trying to
moved up.
sandbag you.
This is the EKG. And I promised somebody in the audience I'd show them how to do this.
Oh, okay. Who wanted to, who was you talking to?
So
You remember?
I don't remember, but they asked me, how do you hook up epicardial wires to record a 12-lead EKG? So I'm going to show you. But this is an EKG. Can anyone figure out what it shows? It's like, probably can make some guesses.
Yeah, I guess.
Is it atrial fib? Is it atrial fib, and why not? It's group beating, so it's regular, repetitive pattern. So whatever it is, it's not going to be atrial fib.
But it's actually not Wenckebach either. This is probably one of the few cases where group beating is not Wenckebach. So let me show you what it is, because we can, it's group beating, but there's a P wave here, right? And maybe there's a P wave here, and then it looks like there could be some P waves here, but you know, it's post-op. They did 2 valve replacement. Hard to know what's going on. So you're not sure what's going on, and you're lucky enough to get an atrial epicardial post-op cardiac surgical patient, you can hook up the atrial lead to V1, and then you have some idea what's going on.
It's cool.
And so it's a cool tracing,
Very nice.
but I'm going to show you how to hook it up before you leave, so everyone can leave here and say, I know how to do it. Okay, what is the rhythm here? Junctional, conducted, junctional, so it's sinus bradycardia.
Isn't that first one conducted?
I think it is.
Oh, I thought you said
I'm
junctional.
sorry.
Yeah.
Starting from the left, it's some sort of atrial rhythm that's conducted, followed by a junctional beat, probably retrograde. You see the morphology is a little bit different than here. Retrograde comes around, turns around, conducts, junctional, junctional, conducted, junctional, and then a burst of what looks like atrial tachycardia. So
Well,
that's what
actually,
it is.
it starts with a V, though, doesn't it? The little
I
burst.
know it's not AV no reentry or something.
I mean,
It starts with a V.
Well, because you
so
said
I
the
don't
other,
think-
you
I
did
don't
say
think
the
the-
other was an echo, so I thought you said the other you thought was an echo.
I thought
That one in the
This
middle.
one
So
is
couldn't this
probably an
just
echo.
be a run of reentry tachycardia or something?
could be, I don't remember whether the VAs were linked or connect,
Okay.
whether VAs were constant. It's just a short run, it probably was atrial tachycardia. But here, so you see this once and for all. This is how you hook it up. This is, obviously, there wasn't a patient, we just did this on a sheet, but here's V2, V3, V4, V5, V6. Imagine this is a patient's chest, and V1 is hooked to one of the wires. It doesn't matter which wire. It doesn't matter which wire. And the other is hooked, okay? You can see here is left in the, whatever the call the the connector to the temporary pacemaker that the surgeons use. So one is left here. Either one can be used. Obviously, when you're hooked up, you can't atrially pace simultaneously, but you can take this out, do some atrial pacing, and then record again. So this is what it looks like. That's how to hook it up. Remember that. It's a useful technique.
Good.
Surgeons usually leave the wires in for a bunch of days. They usually just pull them out before patient goes to the floor. It's a tool, use it.
Is it a unipolar EGM or a bipolar EGM?
V1, unipolar or bipolar?
It's going to be
Yeah.
unipolar. He's got one lead and then the other is indifferent electrode.
Is a ground,
all right?
Indifferent.
So that's just connected to the, whatever, the temporary
box,
pacing.
yeah.
The technical problem is whenever I try to do this, is it works sometimes and other times it doesn't because there's a lot of slow activity that needs to be filtered, right? So sometimes the ECG, you can't filter them. You can't change the filter settings. So how do you deal with that? Let's say you're getting a lot of this stuff.
Can't
Slow
you
wave
Can't
stuff.
change the
Can't
filter
can't
settings
you
on an
just
EKG machine.
hook it up as a bipolar to lead one? In other words, you'd have to take both out, but couldn't you just hook those up to right and left or something like that?
You can do right arm, left arm.
Yeah.
I suppose you could make it into a bipolar.
I
but
mean, if you were having a trouble with the
That's a good idea.
unipolar waving,
Yeah.
that's how you get rid of that. Just make it
Yeah.
a bipolar.
make it a bipolar right arm, left
Right, it'll
arm.
be on the limb.
That
Right.
also works.
Right? I don't know.
And if it's unipolar, you change the filter, you change the
You can change
high
the filter,
pass.
right. You can change the filter. We generally get these really, I mean, this is
That's
just a typical
beautiful.
electrogram.
That's
yeah.
really nice. That's really nice.
Okay,
Very useful.
All right, we're gonna switch over to mine. Keep moving here. It's somewhere in the break. Maybe you can tell us. You know, I feel a little bad. You know what? Because this case will take 30 minutes. So I want you to, Matt, go to the next one for me. Just over here. I'll go through them. Thanks, Matt. I'm gonna. It's a long case. I'm gonna give you a couple Brady's just because we haven't done those in a while. I'm wrestling with what to do with all the tracings we gave you that we're never going to go over. I'm thinking the fair thing would be if we just take a little time when we get it to maybe just do a one-liner and send it to Ashita, so, from the rest of the book, the tracing, so at least you know the answer. The other thing I was thinking is, since you all come from places where they're supposed to be smart people, see if they can help you answer it. If they can't, they'll have to ask us.
right. It's the process
Think about
that
it.
matters.
Yeah, it's the process. I don't know. I have sort of a bit of a guilty feeling that we're leaving you all these tracings unanswered. But all right, so we'll keep the table concept. Who would like to take this one? This was actually a maneuver done by a very smart fellow of mine who trained in London, England. And he was a patient. We were called to see a consult, and he went up to the floors, and he pushed on the carotid, and this is what he got. So give him Andrew all the credit. So any of the tables want to take this one? Tell me what's going on. Yeah, great. Go for it.
So starting at the left side of the tracing, we see P wave, a normal PR interval, and a QRS. And there's like group beating throughout the entire tracing you can see. As you go, the third P wave is not conducted. Then there's resumption with the 3 P waves that are conducted with a normal PR that doesn't change. And then a maneuver is done in the middle of the tracing, carotid sinus massage. The PP interval slows down, the RR interval slows down, and then the block goes away. So to me, this suggests a Mobitz 2 mechanism of bradycardia.
Okay, so well, the first part, so pushing on the, everything you said is 100% right. I just want to do a little terminology.
Sure.
Okay, suggest a Mobitz 2 physiology. Well, why? I guess I'm going to ask you, why are you saying Mobitz 2? Because I think you're going to, go ahead, tell me why you're saying Mobitz 2.
I'm trying to say that there's a AV block there's a second degree AV block,
Right.
that where the PR doesn't change.
Which you had before, correct?
Which I had before, but I guess what I'm trying to say is that the block improves in the setting of bradycardia.
So if I can help you, I think what you're really saying is your block is in the His-Purkinje system.
Yeah, that's what I'm trying to say.
Right.
Yeah.
And I just want to caution you that Mobitz 2 while Mobitz 2 is typically in there, you can have Mobitz 2 that's pattern that's not in the His-Purkinje system, okay? It's a general.
You're saying.
So I just don't want you to, because a lot of people use that. You're 100% right on your tracing read, but Mobitz 2 doesn't mean, Mobitz, we didn't have his tracings, but Mobitz described the pattern, right? So Mobitz 2 doesn't automatically equal His-Purkinje, although it usually is. I'll give you that.
Yeah.
So that's what I was just trying to say. So I think you're 100% right. So is this enough just to go put a pacemaker in? This is a patient post-op. He had aortic valve replacement, as it turns out. So I didn't want to give you the stem, it gives it away. Should I just go put a pacemaker in? Are you that confident that I could go put a pacemaker in now?
Does the patient have symptoms?
No. They just call. Surgeons call you for anything, So they see a beat that doesn't conduct, they call you, right? So the patient's lying there. Why are you guys up here squeezing on my neck? It's like, life isn't bad enough. It's like I had my chest open, Now you guys are squeezing on my neck. Totally asymptomatic. It's only a few non-conducted beats. What the hell?
There's disease in the His-Purkinje system.
Well, you think there is.
Yeah.
As I said, do you want to put a pacemaker in, or do you want to do something else?
I think that I think that I'm fairly sure there's disease in the His-Purkinje system, and so I'd want to put a pacemaker. I think the PR interval is normal on the conducted beats.
Okay.
So
Is this a TAVR, Eric, or?
No, this was so many years ago. This was done in, I think it was in the 92 or 3 or something like that. It's a very, I know it has an L on it, so you're thinking it's recent. That's only because during this climate of, HIPAA, I had to go through all of my slides. I have thousands, and I had to put them all into I couldn't this had a slide that had like 192 on it. So they said somebody might know the patient who you took care of in January of 1992. So they made me, so that's why there's an L. This is actually an old slide. And anyway, I'll show you the bottom line. You're 100% right. It's a great read.
Can I ask?
Oh yeah, go ahead.
Did the sinus rate slow?
Yes, it did.
So the sinus rate slowed a bit too.
Yeah. Sinus
That's
rate slowed.
that's an important 101 principle, huh? That whatever happens, first of all, my rule is if something happens at night, usually it doesn't mean anything.
Yeah, so my quote there: never treat a sleeping arrhythmia. Right?
I like
Except
that one.
Torsade. Treats our side.
Yeah. And the second rule is always watch the sinus node to see what's happening,
Right.
because if the sinus node didn't change at all, you suspect that it might not be vagal. But as Eric will point out to you, you can have input from the sinus node and AV node. They're not necessarily the same vagal
Right,
inputs.
that's important. But it did, if you measure carefully, you can't measure on the
it does
screen.
slow, yeah.
It slows.
Yeah.
It
Okay.
slows.
So then would you, so you would not,
Yeah, I
just for
wanted to
my
put a
teaching-
pacemaker. There's no way in the world I could have convinced an insurance company back then to let me put a pacemaker in without proving what's going on. Guy's asymptomatic. It looks like Winky Bach. You know, it wasn't, if you measure carefully, it was a tiny increase. I mean, I took him to the lab because I didn't want to deal with it. And I told them we set up for a pacemaker, let's put the catheters in first, and you could see it's exactly what you thought. It's blocked. And this is a precarious situation. I mean, he was fine there, but you don't know what he's going to be like a week later. He could have complete block, have torsade, die, you know, so he needed a pacemaker. I won't get into what to do with TAVRs. It's a mess, right? I mean, I don't want to get into that right now, but maybe we can if we have a little time at the end, because everybody has their approach to that. There's all kinds of algorithms. I mean, we've changed our own approach 10 times, you know, but, I mean, when you see a non-conductive beat, do you do something? Do you wait? You know, it depends. But in this case, you were 100% right. And my fellow was very smart to do it, classically trained in medicine, you know, in English school. Went up, did a maneuver, didn't just sort of say, oh, look at this. And it slows. And George's point is well taken. Directionally, things move the same way. So you can slow the sinus by 4 or 5 beats a minute, and you can get complete block in the AV node. Remember, you don't have to have the same amount. So if you push on the carotid and you slow the sinus rate, okay? Or let's say you don't, let's say it's like at night, a sleeping arrhythmia, and you see slight PP prolongation and 4 non-conductive P waves. Some people get like all bent out of shape. Now, if you saw a flat line for 4 seconds, you don't get bent out of shape. God forbid you see 3 or 4 P waves not conducted, you're ready to put a pacemaker in. Same pause, same mechanism, but it's up here. Like, oh my God, 4 beats not conducted versus nothing for 4 seconds, right? I mean, this is psychological thing, you know, about people hating to see P waves with no QRSs. It's all the same mechanism. That's what George is getting at. If you prolong the PP interval and block occurs, it's vagal. It's vagal. And the degree of vagal effect on the sinus and AV nodes can be quite different. And we looked at that years ago. I'll get an article. I finally published all this stuff at a place recently because I get tired of people asking me. So I put together almost 10 years of research in an article we did for a symposium. And I'll be happy to give it to Medtronic, and you guys can read it. It really is like 10 years of work. And it's nice if you're not up on the autonomics. If you know the autonomics, it's like a review. But at any rate, I learned all this by just doing the studies that you can't tell the degree, but you can tell the direction, right, George? So any slight prolongation of PP interval preceding AV block is vagal. Okay, so it's a great job. So I just sent him down and said, we're going to put a pacemaker in you, but we're going to put a catheter in first.
Can I go back to your ECG, Eric?
Yeah,
and,
certainly.
Tell me what's happening. Is the vagus actually causing block below the node?
No, vagus slowed the rate. Oh, you mean on the first left-hand side?
On this, yeah.
No, the carotid side, this is where he wrote it on the tracing. The carotid sinus massage was during the whole thing. He just put it on the bottom here. In other words,
Yeah.
the slowing occurs right here. Okay, it starts to slow, and it slows a little bit versus these. If you actually put your calipers on it, which I can't do from here, you'll see that these PP intervals are slightly longer, not huge, but enough in this patient to allow 1-to-1. Yeah, that just enough to allow 1-to-1
All right, so the carotid sinus did not cause the block.
No, it slowed the rate and allowed 1-to-1.
So I think that's an important thing to remember. The carotid sinus in this case did not cause the block, because if the carotid caused the block,
that's AV node.
A different.
Yeah, so that's what I mean. People get messed up. I mean, I didn't want to change the slide because he did it, and I think he did a wonderful job, so I never moved it over. But he pushed on the carotid, and he just wrote underneath it. But if you look at the PP intervals, they start to slow when 1-to-1 comes along. And he did a great job. I remember he called me, he said, Eric, we need to put a pacemaker in. I said, really? Bring me the tracing. And I said, okay, I'm keeping the tracing and you can put the pacemaker in.
This is a variant on the theme of you put them on a treadmill and it gets work.
Exactly, that's the other thing, right? You all know that with Dr. Klein saying that the same thing works when you increase the rate and it's below that, you get greater degree of block. That's a little more dangerous, by the way, right? Because you better get your ass in that treadmill lab if you want to do that. Because if you don't warn them and there's just a tech there and they get boom and they pass out, it's on you. So yeah, if they get to our side, yeah, then it's really on you. So that's a little riskier, because you to just get your butt in there when you do it. Very well done. Nice read. Nice read indeed. You guys are a good group. All right, we'll do this one. How's that? This is the next one in that series. I love this one. I only have one example of it. Who would like to take this one? You've learned a ton of physiology in the last 2 days from all three of us teaching you stuff. Just put it all together, make your measurements, look at the tracing, and you'll get it. It's the only case I have like this, so you're not getting it. How about that? I won't give you this tracing. Now they'll go out, Ken, and they'll make a copy of it, and they'll show it at the next meeting. Right, George? This will be on Twitter. It's like, Dr. Pete said we're not supposed to show this, but we're going to show it. All right, which table? Nobody from the right here is opined in a while. It's just, how about one of the tables here? Young lady in the middle. Go for it.
Well, in the first glance of this tracing, it looks like a group beating with the first three complexes conducting with a prolonging PR interval, and then a non-conducted P wave.
So I'm going to stop you right there and go to my Michigan buddy. I forgot your first name. Mosa. Sorry, Mosa. Based on you liking to use terms for sites of block, are you willing to say this is AV node? Because she just described Mobitz 1, right? So do you want to put it in the AV node? Don't say any more than that, just yes or no. No. Thank you. Go ahead. But you see the problem you get into if you start to play the game of Mobitz 1, Mobitz 2, where the block's occurring, you can put your foot in it, right? So it's Mobitz 1 you describe, right? Now go, you're doing a great job. Go ahead.
And then it seems like the pattern is repeating itself. And then if we compare the first PR interval in the second group beating, it's shorter than the last PR interval in the first group beating. So yeah, again, that's confirming just Mobitz type 1. But then we see that the morphology of the QRS is, when we look at the first group beating, for example, the morphology of QRS is widening. And then maybe a delta wave appearing in the beginning.
I'm sorry, what did you say?
A delta wave?
I'm not hearing you right. So
delta wave, no.
No, that's a clue. That's a clue to maybe change your mind. You're doing so well. Why do you throw a delta wave? Why in the world would you throw a delta wave in? Come on, I didn't hear that. So I'm gonna let you I'm gonna do a mulligan.
Do over.
We're giving you a mulligan. On the Sports Center last night, they were giving everyone's broken brackets a mulligan. So all the guys were allowed to redo the Final Four. So go ahead. So I'm not gonna let you say.
Can I just make a comment, because that's a very common thing. What's a delta wave?
It's just a pre-excitation, basically. So
Well, it's generally speaking referred to it as a fused complex, right?
right.
Where the beginning part is over the accessory pathway a little bit, so there's a little notchy thing, and then the AV node catches up, and it's all of a sudden very positive, or the rapid part takes over. Okay, so the delta wave is fusion, where the fusion is relatively minimal, with the initial part's pathway and the rest of its node. If it's fully pre-excited, it's not a delta wave anymore. It's fully pre-excited. So if you look at what you're talking about, you get your QRS widens, but but there's no delta wave. I mean, there's no
Right.
notch. You'd expect to see some sort of notch, and then it should be fused. This almost immediately goes into it's whatever, bundle branch block or whatever it is, all right?
Yep.
So it's not, so understand what a delta wave is. And the other thing too is when you throw out jargon, it's bad because now you're thinking WPW and you leave your brains at home, right? You forget about the other things. So try not to use jargon until you figure out what's happening.
Okay.
So you're
Widening of the QRS. And
right. So you're doing perfectly well until you threw the term out and you got the two of us off on a tangent because we like terms to be correct. So let's take in the middle. You're doing a fabulous job. This is really a tracing that you may see again, but my guess is you won't for decades. So, I mean, because I'm an EKG, I love EKGs. You know, I see tons of patients and I see lots of EKGs. And I mean, I have a huge collection and I have one of this, you know, so start in the middle here. You've done a great job. So let's just do one. So starting here, is the QRS wide or narrow?
is narrow,
Okay, and then how about this one?
is wider.
And how about this one?
I think probably the same or maybe a little wider.
Okay, and what's happening to the PR from here to here to here?
It's prolonging.
Okay, so again, to George's point, why would a delta wave come out? I mean, when you have a prolonged PR, usually a delta wave is with a shorter. It's not, you don't have to, don't think I'm sandbagging you. This is probably what you think it is. This is this is monitored leads, right? So this is kind of a bundle, right? Probably a left bundle, but this is a bundle here, right?
Yep.
And then what happens?
And then it's a non-conducted
Right,
period.
and then you have a long pause, and then what happens?
And then it restarts with a shorter
Okay, so it's
PR.
repetitive, right?
Yep.
Put it all together. It's perfect. Go ahead. Just tell me what the mechanism is. What's going on? So would you call as far as the type of heart block, what would you read it as?
Well, given that the QRS is widening,
Now forget the QRSs for the moment. Just what's the pattern?
the pattern is Mobitz type 1, so
Yeah.
thank you.
So now your job is to tell me where it's occurring, right? Because it's just Mobitz 1, asymptomatic. Do I have to put a pacemaker? Do I have to study the patient? Do I tell them, you know, hey, that's great. You know, you're doing fine. You only have Mobitz 1 block. He's the uber pacing guy. Is asymptomatic Mobitz 1 an indication for a pacemaker?
No, but
No. So send him home, right?
this is a special case.
This is a special case.
Let me ask you, Eric, you know, there's Mobitz 1 and there's Mobitz 1.
Right.
This is sort of like a pretty slight prolongation, right? I mean,
No, it's prolonged.
No,
Yeah, right. Well, that's all part of the clue, though, right? Don't give
yeah,
it
that's
away.
what that's my point. So
Yeah,
it's important that it's a kind of it's a Mobitz 1 technically, but it's not huge Mobitz 1, right?
Right.
You have to-
So what he's saying is, it is
Yes.
Mobitz 1, but the degree of increase in the PR isn't dramatic. Okay? All these are little clues, but the most important clue you nailed. You just didn't call it, you got on our nerves because you called it something we didn't want you to say. So, on our theoretical nerves.
It's not just a semantic thing, because
No,
if he says that, then she's
I know that.
It's totally
That's
misleading.
why I didn't hear it. That's why I refused to even listen to it. So it's a bundle, right?
Yep.
So you went from a narrow to a bundle. What does that tell you as far as what's going on mechanistically? Where is it happening? Anatomic. Remember that line I drew you? So is it more likely in the AV node, in the His, or somewhere in the His-Purkinje system? That's the key, because he just told you he'll come after you. He's that guideline guy who's saying you can't do pacing in an asymptomatic Mobitz 1, except like he just whispered to me, this is an exceptionary. Yes, this is an exception. So where is the site of block, do you think?
Let me ask you a question that might be helpful, all right? What would you expect if it were Mobitz 1 in the AV node? Okay, you might expect a little bit of longer PR, but what would you expect? Would you expect?
Would expect normal QRS.
You would not expect to get the bundle
Right.
if it was vagal, because if anything, you're slowing, it's giving you longer time, okay?
Gives
Because
more time
the
to
node
recover.
protects it. So it's easier the way to look at it why it's not AV nodal than why it is subnodal.
So where do you want to put it? You
Um,
can have help from your table buddies.
I would put
Pick
it
a site, AV node,
infrahis-
His,
Oh,
or Purkinje system.
He sounds like a plaintiff's lawyer, actually, so
I would put it,
don't let him browbeat you.
it's most likely infrahiscine or
Intrahiscine?
intrahiscine or infrahiscine.
Infranodal, anyway.
Well,
Infranode. It really doesn't matter, right? It's somewhere in that
Infranode.
area. All right, you want to see? You don't think I'm just going to leave you here, right? There's no way this person wasn't getting a his bundle study. I'm telling you, a million years. But I also sent him down for a pacemaker. I just told the guys to get some tracings. So it's infrahiscine Winky-Bach. So not bad, huh? Pretty cool.
It's intrahiscine because
Well,
block
well,
B has the first component of the His.
well, I think it's, it depends if you think there's two hisses. I could not, this is what they sent me. Here's the problem. When you send your team down to do it, and they have 7 other things to do that day, they put a his bundle catheter in, like I asked them to, and they recorded a large A in an infantile hiss, and I told them this is a rare case, spend 10, 20 minutes, find if there's two hiss bundles, and this is what I got. So I can't prove to you there's a split hiss here, as much as I'd love to.
Okay.
So I can't say anything more than it's somewhere is Winky-Bach in the His-Purkinje system. I would have loved to have shown you exactly where it was, but this is what they gave me, so this is what I have. And I remember calling them, and they said, they were so proud. They said, Eric, you're right, it's block below, it's Winky-Bach below the His. I said, that's not what I asked you to do. I asked you to tell me if it was Winky-Bach below the His or in the His. They go, oh, well, we put the pacemaker in, the guy's in the recovery room.
So Ken, is this a candidate for conduction system pacing?
I think you'd have to put the lead in the His bundle and see where the site of block is, and that's
What's your
sort of
guess?
a fun thing. I guess I think intrahiscine typically has, it doesn't look terribly wide, so I bet you it was intrahiscine.
Yeah, I just don't know. But I tell you, the reason I smiled on this one when I got it was because I only saw one other case like this, and I sweated more than you did, because I was in front of about 2,000 people. I was asked to join the faculty years ago of an unknown ECG course at one of the major meetings. I think it was American Heart. And Willis Hurst, you know the textbook Hurst? Willis Hurst was the chair. He was running the meeting. And he called me once and he said, Eric, would you like to participate? And I thought, wow, this is cool. Be on the stage with these guys. It's like, wow. And I was there with a bunch of ECG gurus. And I was actually the only EP on there. And he showed me something like this. I had never seen this before. And I'm in front of like 2,000 people, and I'm sweating my butt off. And I'm looking at this thing and saying, what the hell's going on here? And it suddenly hit me. I know it. It's one of those kind of things. It's like that famous movie, where it's a chess about, what's the thing, Searching for Bobby Fischer. I love that movie. And, remember, he sits there at the board. He sits there, and you could see his mentor there. He sees his face and he goes, he's got it. He knows the next 12 moves. He's finally got it. And that's kind of what it suddenly hit me, was like, I think I know this. I never saw it before. And I opined on it, and Willis Hurst said, Eric, it's the only case I have like this.
Wow.
I agree. Of course, he didn't have
I'm
any. He didn't have any, but I sweated my butt. I mean, I looked at this and said, what the hell's going on, So good for you. You did a lot better than I did. I really sweated this one. Of course, he didn't have any intracardiacs, and he just said, but the clue here, the real clue, George pointed out another one. Anytime you have small increases in the PR, you got to think, and even if it's narrow QRS, think intrahiscine Winky-Bach, because usually AV node is bigger, but that's not 100% rule. I have plenty of examples, as we all do, of in the AV node where there's not major things. So that's not 100% rule. I wouldn't necessarily study someone like that. But anytime you see a progressive widening of the QRS, why would, like George said, why would that happen? Unless his Purkinje system is diseased. And then you have a non-conducted beat, then you have a pause, and it comes back narrow. Well, slow rates tend to favor, conduction over the His-Purkinje system, right? So if you put all the physiology together we've talked about, it's like, aha, I got it. You did a great job, really great job. Just forget the delta wave. All right, you know what I'm gonna switch to, if it's okay with my two buddies here? How about if we do the unknowns?
Yeah.
If we can get those done, and then we'll let everybody take a break. What do you think? You okay? And give some feedback. So I guess I could just ask you, would you like us, I mean, don't expect it to happen tomorrow, but would you like us to just give you one-liners on what's in the book we didn't cover, like what it was supposed to be? What do you think, George? You mind doing it? You'd rather not do it?
I don't like that often because half-assed doesn't work, huh? The answer doesn't mean a shit. It's how you look at it that means something. So I think that I would personally favor you having a look at it. If you see something that's one of ours, just scan it and flip it to us. The good folks at Medtronic will give you an email. Certainly, that's what I would prefer.
All right, so for George, you can do that. I don't want a bunch of people scanning things and sending it to me.
Yeah, and I don't mind that. Huh?
Because I'd rather just send you a list of what they are. And if you have a question about it, even though I tell you here's the answer, I'm happy to interact with you on it. You just work through Medtronic, they know my contacts. We'll set up a call at night and I'll go over it with you. How's that? So I'll get it, but I'm going on holiday visiting some friends in Scottsdale for a week. And so don't do it this week. And don't do it over the weekend, because that's Final Four. And I'm not going to answer any of you over the Final Four. But I will do it after that, I promise. So,
on the other hand, I'm housebound for the next 3.5 weeks.
And how do you want to
feel
handle
free.
yours, Ken?
Just send me an email and I'll give you the answer to whichever ones I actually put in the book.
All right, so you hear how we're going to do it. After I get back, Sheeta, I'll send you, where is Sheeta still here? She probably stepped out. Anyway, I'll send a list of the ones, I make a list of all my tracings just so I don't forget which ones are which when I show them to you. I have the ones I did and I didn't do. The ones I didn't do, I'll just send you what the answer was supposed to be. Again, if you want to go over with me, get a hold of a Sheeta or Medtronic, set up an evening call, because I don't know about you, but I work during the day. So we'll do an evening call and I'll be happy to go through it with you.
I believe they work during the day too.
No, I was teasing. All right, so how about if we do the unknowns? Do we have, how do you have the unknowns set? Matt, do you have them, the tracings? We got them down here. I don't know how you did it. Okay, I don't know how you want us to do this. We haven't done this before. So Ken, George, do you have any ideas?
Well, we throw up this.
Throw them up and we'll opine. We
Let the person who submitted it come on up here.
Yeah, why don't the person who submitted come up and pimp us? Who's the first one? Ansel, where you at? Yeah, come on up, Ansel. I made a few notes. I don't know if it's right, but so
do we want Ansel to pimp his colleagues here, or there's just
how do you want us? You want us just to opine? You want us just to so you want us just to tell you what we think's going on, Ansel?
Yes.
All right, sounds good to me. You guys,
Now,
anybody?
before we opine, do you actually have intracardiacs you're going to show us?
I don't. We did the case, but I can send you the intracardiacs because I did this
We'll want to
case
see that, but
a couple weeks
Yeah,
ago.
well, I have an idea, but I don't know if it's right.
So, Ansel, you know what it is, of course.
Yes, sir.
So it's no fun if you talk about it. I mean, what the hell's
Absolutely,
that?
I'm
I
happy
mean,
to pass it.
why don't you just get the table next door to talk about it, and you can help them along? So what's your plan when you look at this? How do
We're
you
not going to
frame
spend
the
an hour on
problem?
this one tracing, so you have to be this.
Yeah. So first is I see narrow complex regular tachycardia.
Perfect. Good
That's
start.
easy. So then I'm trying to scan for P waves.
Forget it.
I'm looking in B1, and it might be at the end of the QRS, like a RSR prime. That's a candidate, and another candidate is just in the middle, like negative deflection. I don't know if that's the T wave or a negative.
How about
T wave.
lead 2? What do you see in lead 2? Do you see that negative, a little P candidate at the end in lead 2?
or prime.
Hold on.
Yeah.
Yeah.
How come this
If
is,
it's a P wave, is it high to low or low to high?
sorry,
Low
Here.
to high.
Low to high.
This
So you have a
little
P
ditzel
wave
here.
candidate, a good P wave candidate,
like
Yep.
right
and the
there.
P wave that's there is low to high.
Yeah, and you also have this little ditzel here, George.
Yeah, you also see it at other places, but
Yeah.
the key ones are the inferior ones because you have some idea of vector, and
Yeah.
V1 you often see it. What would you want to see to prove that?
You want to see sinus, of course.
Yeah, I would like to see the
we don't
EKG and
have
sinus to
We
You
don't
don't
have
want to see sinus, and he hasn't given it to you.
No.
But you're
So-
missing a key point that hey, that's EP 101. He wants you to do EP 202. Talk about the cycle length.
Well, let's
sure
say
that-
let's
that's-
say it's a P wave. All right.
Well, you don't. Okay, this is what happens. This is fine. This is just showing you two different people how they viewed this when we got it as an unknown.
Okay. You play it out. And then I'll play it out.
You use the P wave, which is fine. I think the cycle length is fascinating.
Yes.
Well, that's a secondary problem.
So the intracardiacs.
That yeah.
Yes.
We will take your word for it, buddy. You don't need the
Yeah,
intercardiac.
you don't have.
So looks like like now you're saying in V1 like so there is
Well, can I help you a little bit because you haven't measured? You don't have the tracings, right?
no.
I measured these. I will tell you that it's equal. The shorts are shorts and the longs are longs, and they're equal.
We call it cycle length
Yeah, cycle length
alternates.
alternates. Yeah,
okay.
I measured it, so it is cycle length alternates, just so you know.
With the cycle length alternans is QRS alternans also, and you don't have to see it in every lead, but you certainly.
So in other words, these two are equal to these
these two,
two,
yeah.
and these two are equal, and it's a repetitive pattern. So it's what we call cycle length alternates.
Short, long, short.
Short, long, short, long. So now, put your hat on, physiology. I don't know what this is, but
Yeah.
in cycle length alternans, something's got to be alternating to cause cycle length alternans. And you just got to me, that's the key.
Right.
I don't know the diagnosis, but I know what I would call it, and I could be right or wrong. Like I said yesterday, and I think George would probably say the same, and Ken, that when you don't know something, you just kind of hone in on what you know about, and you make a diagnosis. You may find you're wrong, but you're not going to be in left field, hopefully. You know, you might get in the lab and say, oh, it was that. I thought it was this. So there has to be some reason.
So I'm trying to think what is involved in the circuit that will
That's right. That's the way to
that will
think.
cause the
Good.
alternates. So I
Good.
don't know if the AV node will
Can
do
I-
that.
Yeah, go ahead,
Can I
George.
give you an alternate thought?
Yeah, go ahead.
So sometimes when you have a pattern like this and you say, okay, I think that's a P wave, then you play it out, that scenario, and you say, well, okay, let's say that's a P wave. I'm going to pretend that that's a P wave, all right? Then I ask myself, if that's a P wave, what's happening? And Eric, the cycle length is a secondary thing, but if that's a P wave, you have to, what is your differential diagnosis if that's a P wave, regardless of the cycle length?
So AV-NRT could be
AVNRT versus,
it would be like ATAC with a long PR.
ATAC,
interval.
all right? Those are the only two things it could be, all right? I mean, theoretically, it could be junctional tap, but it's an adult, all right? So theoretically, you've only got two choices now. If it's a P on QRS, you've only got two choices. Now you ask yourself, is there anything on that tracing that helps me distinguish those two? And now we go to Eric's point, right? Which I think is very important, but I just wanted to
Yeah, no, it's
give
like
them
I
the
said.
methodology to think through and pretend that it's
Here's one of the problems when you've done this for years. I skipped that part. I mean,
Well, he can't skip it.
yeah. I mean, I'll be honest. You know, sometimes you know certain things and you just skip that part. And so I went right to the cycle length alternates.
I don't want him to skip that
Yeah,
part.
no, it's
because
a good point.
He hasn't decided yet. So I'm looking at that and I say, I'm going to assume that that's a P wave for now. I could be wrong, but I'm going to make that my number one choice. I'm going to play this out.
All right. So
And if that's a P wave, then I've only got two choices.
Right.
And how does the alternance help me with those
right.
two
So
choices?
so now I'm going to add to you now. Okay. So what George is saying, he's giving you differential, right? If it's atrial tach and there's alternans, now he wants you to hone in on the relationship of the RP. Would that be fair?
Exactly. Who moves first when
Who
a
moves
cycle length
first?
prolongs, the P or the QRS?
Who's
Who moves
married
first
to whom?
when it prolongs?
Who's married to whom? So put it simpler to not confuse you.
Yeah, I
Is the
understand the
P
question.
wave in the same position versus the QRS in all tracings, in all complexes? That's a simpler way of him looking at it.
It's equivalent. It all
Right.
depends how
There,
your
yeah, so
brain
you-
wants to
say
look
yes.
at it.
Yeah.
So I will measure the R to the P.
You don't have to
Okay,
measure
so-
anything.
Yeah.
You
so
just
it
look
says-
at it.
Yeah.
Just look at it. Does it
The-
change?
The
No.
cycle length prolongs.
Okay, it doesn't change. You're good. You're doing great, right? You're doing great. Now you have two choices. Which one's more common? Right? You can argue.
99% of the time.
Yeah, right. I mean, you could argue some bizarre thing, but if the RP is staying the same and the PR is changing, is that more, I mean, what does that more likely tell you? The AV nodes involved or not involved?
It's involved.
So it's AV node dependent.
Yep.
Is atrial attack AV node dependent?
No.
So what is it?
ABNRT.
Exactly, it's AVNRT.
That's what we
But
would say.
the other way of looking at
Yeah.
the VA, other people would call it VA linking. Eric doesn't like that.
I hate linking.
But the VA, because it has another connotation in EP that nobody thinks about anymore, but
It's not
the,
terrible.
but the VA is linked, and the cycle length prolongs. What's the first guy that moves? If it were an atrial tachycardia, it would be the A, right?
Right.
And here it's the V that
V
moves
is driving,
first,
yep.
right? And the A follows with the same RP.
So
that has to be AV node reentry.
Right.
And now your challenge is, why is it doing that?
Right? And here's the real thing that bothers me. Cycle length alternans is in the AV node, but typically AVRT. If you look at most patients who have cycle length alternans, it's AVRT with dual pathways. That's what happens. This would be AV node reentry going over one another. That is extremely uncommon. But since the RP is so short, I'm not going to call it AVRT, but I'm just telling you, if you took 100 cycle length, I mean, I've looked at this for years. You look at cycle length alternans, it's right, it's classically AVRT with dual pathways. So this one, if it turned out to be AV node, is really cool, because this is AV node reentry, alternating, it's same fast,
Same retrograde.
but two
Same
different
retrograde.
Antegrade.
flows.
Right.
So
Two
it's absolutely
antegrade.
beautiful. We'd
So
love to see
that
that
is
recording.
great tracing.
Yeah.
And I wish you, that is
Send us some
fabulous.
cardiacs.
No, he's not sending you. You
Can I-
should publish it.
Prove it.
No, you should publish this.
Can I-
This is actually more rare than you think it is,
Yeah.
because cycle length alternans is bread and butter. I mean, everyone sees that. But cycle length alternans with AV node reentry is not that common. I mean, it's really, really uncommon. This is cool tracing. Thank you for bringing it.
Before we let this man off the hook,
Oh,
he's doing so well, and you don't bleed, which is very good. I hate to say.
yeah, can I tell you what, there's a rule about bleeding?
Yeah.
This is something, there was an article written when I was a young guy in the field about what not to do with the microphone. It's a great article. I wish I could remember where to get it. But one of the rules was never bleed at the mic, because once there's blood in the water, all the sharks appear.
Yeah.
So it's better to say at the microphone, I don't know, I'm not sure. You put your ass on the line and you're wrong, blood in the water, you see people come to the microphone and it's like, oh no moment, like, why did I do that? So never bleed at the mic. It's okay to say I'm not sure.
And no tears, no tears.
No tears.
Adults
There's no
don't
tears
cry.
in EP. So it's okay to say things like.
No
that's
blood,
a-
no
it-
tears.
No,
Good.
here's a classic one.
What's the
You
matter,
could
Sidney? You don't like that advice?
Yeah, that's a good idea. I'll take it under advisement, right? If you're presenting an abstract, and you don't know, don't fake it. Don't say we didn't study it. Give them credit. You want to bring them in, no one will tax you when you give them
Great
credit.
question,
Say,
don't know.
Great question. You know, we'll have to go back and look at that. Next question. I mean, no, was he going to come back and say you should have looked? No, he's going to look like an idiot. So now you're off the hook. You're off the hook. You just go on to the next question. Don't bleed at the mic. Telling you, sharks come.
Okay, I want you to give me one other reason why that's probably AV node reentry. And I'm just looking at V1.
Really?
And,
You don't think he already did that?
Why, is there one more reason why that's probably AV node reentry? Why that guy is probably a P wave? And I want you to look at that big diastolic interval. It's a beautiful, clean tracing. And you see no suggestion when you check the middle between those two putative P waves. There's nothing in the middle. It's a long diastolic interval with nothing and then a clean tracing. It has to be in a node, right? So that's another clue that it's probably all likelihood AV node reentry, all right? If I can give you one more anecdote here.
Yeah.
I was chairing a session, and Shen Chen, who was a very smart guy, I had a young fellow giving his first abstract, very, very nervous. And he's standing on the podium, and Shen Chen asks a question, right? And you got to know Shen Chen. He's a very smart guy, but his English is totally incomprehensible, absolutely incomprehensible. So after his question, the guy turns to me and he said, "What did he say?" I said, "I have no bloody idea. Just tell him it's a good question and we'll talk about it at the end of the session." Sorry for the anecdote. Move on.
All right. Well, since we'll get to the next person, but I have to tell one last anecdote. Since you said that.
Please.
It was the greatest moment I think I've ever seen at the microphone. So I started off in a cell lab at Duke because that was the Duke tradition. I never wanted to be a microelectrode guy, but at Duke, George started in a dog lab. Kenny, were you dog lab or a cell lab? Ed Pritchett. So I started in a cell lab. It was a great education for me. I never would have done a year of basic science. So I learned tons of stuff. That's how I got into the autonomics. But anyway, that year, Harold Strauss was my mentor. He and Mel Scheinman were good friends, and they were working together on some stuff. And so we all went to the national meeting, and they had too many abstracts accepted versus presenters. You're only allowed back then to present one thing. So there was a guy on a paper, that really didn't do the study. He was part of Mel's group. So he was on the paper, and he presents the thing. I'm sitting next to Harold, Dr. Strauss, and he's scared crapless because he knows someone's going to ask him a question he's going to go under. So who gets to the microphone? Langendorf, Richard Langendorf, the world's most famous electrocardiographer, to ask him a question about the thing. And Harold is just about slinking in his seat because he's the senior author and he figures he's going down big time. And you could see on the guy's face, he had no idea even what the question was. No idea in a million years what the question was. And Harold's going, "Eric, I'm going to be so embarrassed." And the guy says, "Professor Langendorf, I'll consider that a rhetorical question, and I thank you very much for it." And that was it. And Langendorf said, "Oh, okay," and sat down. And it was like the best. I said, someday I want to use that. And I've yet to be able to, but someday I want to use that. I mean, can you imagine that moment? I really thought Harold was going to commit suicide at that moment because Richard Langendorf, of all people, oh my God. So anyway, don't bleed at the mic is the bottom line. Don't bleed at the mic. But anyway, that is a great case. Congratulations to you all. When you got in there, I assume you bladed at the os? Yeah, that's the thing. It doesn't matter. Cool tracing, you guys should report it. It really is more uncommon than you think. Okay, AV node reentry with cycle length alternators is not a common thing. So you guys ought to put that out there. That's a fun case. Thank you for bringing it. All right, next case. Who's the next, who we have? Okay, Jorge, is that pronouncing it right? Jorge. Jorge, sorry, I'm very sorry.
Jorge, you don't know that, man?
All right.
This is the United States. That's the second language.
I'm from Panama.
Come on.
Yeah, give me a break.
Okay, so this is a young gentleman, 48-year-old. He presented with altered mental status, and I'll give you that. He's in the emergency room.
This one?
Yeah.
Yeah. This almost looks like yours from yesterday, Ken.
I know.
Yeah.
Or somebody, right?
Really,
It
really
like-
wide QRS.
I thought,
It's a
did you
really
steal
wide-
Ken's trace?
I know. I didn't see the booklet before.
Even though it's not really wide in all the leads, every single lead, it's really wide in a lot of leads. And when you have a wide complex tachycardia, and it is wide, and you have to think about, as George showed, and I think I showed also, drugs and hyperkalemia. You don't really see any P waves. So, well, there are P waves in 3, actually, or maybe I think I see a P wave.
Yeah, I wasn't
2
sure.
and
I was looking
3.
for P waves.
But, hyperkalemia has to be high on the list, particularly when you don't see good P waves.
Is he pimping the panel or is he pimping his fellows, his colleagues?
No, we're just answering to move along. No, this is like yesterday. I mean, I actually wrote on here, did you steal Ken's tracing?
Yeah. No, I saw it and I was like, oh, that's exactly like mine.
It's okay.
But
I mean,
It
so
almost looks
potassium was
identical to
4.
what Ken showed
But the
yesterday.
list of drugs that can cause this is quite long. Obviously, a tox screen, but as Eric pointed out, there are a lot of antiarrhythmic drugs that can do that, mostly 1C drugs. Probably, unless there's some history of him being on drugs, I want to know, the first thing I want to know is K, creatinine.
So K was 4.2.
Can I throw in a thought here?
Yes.
If I use my approach to life, which is fairly simple, and you haven't really given us a hell of a lot of information.
Yeah,
It's very, if I were my patient, the first thing I'd want to see is an old ECG, of course.
Yes.
But I look at that and I have a nice 12 lead more or less, and it's a little fast. So it's the tachycardia by classification. And what's the morphology? Is it aberration morphology or is it a VT morphology?
Aberration.
It's I think it's a
It's
VT
looking more
morphology.
I think it's unclassified because I think
Well,
I think it's one of those that you can't. It's certainly not aberrancy.
Well, it's
classic
sort of right
aberrancy.
bundle, left axis.
Yeah, but look
Sure.
at V6 and
Yeah,
look at
but that's the V6, that's the
AVR.
way V6 looks.
Look at
Right
AVR.
bundle, left
RVR is upright.
QR, you have a QR and AVR.
Yeah.
I mean, it's not classic aberrancy.
No, but I think it's a VT morphology.
Yeah, that's what I'm saying.
Yeah, so
Or
everybody agree.
something like VT, a masquerader of VT, like, drug like
Right.
flecainide or propafenone, toxicity or one of those gigs, which you can't tell apart is what I'm saying.
Exactly.
Yeah, you
So,
need more
but
history.
the morphology is on a 12 lead. It's your first kick at the can. So after my first kick at the can, I'm going to say it's VT. Now, the other reason I say that is that right bundle, left axis is almost never an aberration pattern. It's either right bundle or left, but not both, unless they have a pre-existing one, all right? So usually a right bundle, left axis, when the pre-existing is normal, is VT, all right? Until proven otherwise. So we start with a VT morphology, and we're all aware that the VT morphology is a probabilistic statement. So now these guys are looking for P waves, they're looking for other explanations why it would be wide, and that's fair enough. I just wanted to take us one step back, that if I know nothing else about this, it looks like a VT morphology, but I'd really want to see a baseline 12 lead.
Yeah, so that's what I was going to, when I went over this last night, I wrote down all the same things that he said. I said right bundle, superior axis, RS less than 1 in V6, QR and AVR. I mean, I just wrote down the observations and said, it's VT to prove otherwise. I need more. No, it could be flecainide toxicity, propafenone toxicity, could be, like Imodium. I mean, there's a whole bunch of other things that I need to know about. But if that's the point I'm getting at with George, this is not aberrancy, but it doesn't mean it's not SVT with something else going on. But it's not aberrancy, right? So I need more information at that point. I actually thought I saw a P wave in there, but I wasn't positive.
What's that
Maybe
sharp
down
guy
there
in
in
V1?
V1. Maybe you
Yeah,
can
I
see a P
wasn't
way there, but
positive.
it's
Yeah, I wondered about that. But so that's how I'd approach the case. And if it's in the ER, if the patient's stable, I'd run all the lab work, talk to the people, try to figure out if there's something else
Get
going
an old
on.
ECG.
Yeah,
Yes.
So
So I don't have an old ECG, but it was basically normal like 3 years ago, and the guy's intubated. We went over the drug list, and he was on nortriptyline for pain.
Yeah.
So that was a high on our differential. Potassium, all the electrolytes were coming back normal
So
creatinine.
did you?
And the UTOX came back positive for cocaine. So it was cocaine
Cocaine.
in the setting, and probably nortriptyline. This was this week, so I still have the UTOX.
So how did you treat him in the ER? What you guys do?
We gave sodium bicarb,
They did it
and actually,
normalized?
whoop, we started seeing
What was the
the
underlying rhythm then? Sinus tach or something?
sinus tach. Yeah, and then we saw it like the QRS started to narrow.
Very
But
cool.
what was interesting is in AVR, we still saw that like that R, that like kind of R prime that is kind of high.
Yeah.
That we saw that it was persistently there, even though it was narrowing on the next
Really?
EKGs. I should have put them there because it was kind of nice
So
to see.
that R wave was like that in AVR, even in sinus rhythm?
Like when it started to narrow,
Yeah.
that still was present there until like
Oh.
it.
Well, that's interesting.
Yeah, and I saw that that's kind of like one of pathognomonic on sodium blockade toxicity.
I think it's a great case. Thank you
Yeah.
for bringing it. Yeah,
Thank you.
I think the message is, I mean, these are unknown to us, right? So you could see how we looked at it. I just looked at it last night and made a bunch of scribble. No, I mean, I wasn't
Yes.
sure.
Yeah.
And I just said, after I put all my notes down, I said, it's not aberrant. That's what I came down to.
Now,
So
the
now you're down to
question that we were
VT
asked-
versus versus
Hold on.
sinus with goofy things going on,
Hold on.
right?
Most right bundle branch block VT, most probabilistic 90% right bundle branch block VT in a not badly scarred cardiomyopathic ventricle is 140 milliseconds. I mean, maybe 160 at most. This is QRS is so wide, it can't be VT. It's got to be, unless it's like a totally dead ventricle or something else is going on. So again, I think it's always good when the QRS, I actually didn't think that, I thought I saw an R in V1 followed by a RSR prime. So I thought it's pretty, my morphology thing, and my morphology thing said, this sort of looks like not so bad for typical right bundle, but it's too wide. It should, if it's VT, it should be 140, maybe 160. But how wide is Bellhausen's VT, George? 120, right? It typically fools us. How wide is papillary muscle VT? 140, 150.
We're kind of all saying the same thing. I mean, I think the message, and we're looking at it differently from how we view, that's going to happen with experts, Like I said, I took a look at the first tracing and I just skipped the first 6 things and said, I knew what it was. I was just trying to figure out why it was occurring. So here, it's not aberrant. There's no way this is classic aberrancy, which goes down to George's point, then it's VT till proven otherwise, and the otherwise is what else is going on. And that's, you guys intubated, you do all your tox screens and you find out the otherwise, and then you take care of the otherwise and hopefully the patient will do
This might be
okay.
a good case for Ken's lead, huh? To get some type of a lead, Lewis lead or something, to try to amplify atrial activity, or get an echo and see if you can see atrial activity.
Oh, good.
Did the patient end up having really high levels of tricyclics?
So, that's still pending. It's a handout, so that was like on Thursday.
So guys, we have an executive decision to make from.
Well, I thought we
I
should
only
do at
have
least
one
another
question.
don't you?
Would you think this
Don't you
is
wanna
like
just get done
Brugada?
with the unknowns
Would
and
you
then we
throw
take
in
a break?
Brugada?
No?
Well, the thing is, they've been sitting there for 2 hours now, so quick two.
Mimicker.
Well, let's ask him. I'm sorry, I didn't mean to.
He said, why is V1, sort of Brugada-ish? And I said, sodium channel blockers like tricyclics give you a Brugada-looking pattern.
Right.
Antidepressants, see it all the time.
So they're asking us to, because we're supposed to break in about 5 minutes. My feeling would be, let's get done with the unknowns and then take a break, unless you all feel like your brains are dead and you want to.
Well, if we get on with it, then time's out anyway. So then
We're
there
going
is
to
no
do,
break.
and we'll just move along. We'll do the unknowns. We won't spend 2 hours on the unknowns. Sheeta, can't you give us 12 minutes? Well, we're asking them. If you want to break now, we'll stop. Keep going or break?
Okay, show of hands. Who wants a 5-minute break?
Who wants to
Nobody?
keep going?
Then Eric.
Let's
Eric
go.
wins. Okay.
They win. Sheeta, don't lose sleep over it. I promise you, we're not
Good.
killing them. We're
all
not
good.
starving them to death.
They've
That's fine.
spoken, Ashita.
All right. We won't do our thing. We won't do 30 minutes on each one, I promise. So we'll just
No
move
more
along to
anecdotes.
the
Ashita.
third one.
No more anecdotes.
Lazum, is that
Yeah, it's me.
pronounced right?
Mosum.
Lazo, I'm so sorry. Yeah, so you have one from us for, can we put up his tracing, please, Matt? Thank
So
you.
this is a consult patient, a patient just after a TAVR. The question is, what can we say about the AV conduction?
Yeah, I was wondering why you showed this, because I was thinking it's kind of simple, and it didn't seem like you'd show a simple thing.
Yeah, it was on a cardiology service, and they
Oh.
had asked us to put a pacemaker in
Well,
most TAVR patients.
the TAVR expert is sitting to my right, so God knows I'm going to let him. I mean, I think I know what's going on, but since the question is what to do next after a TAVR, I'm going to defer to Ken. But I mean, I think what's going on is pretty straightforward.
Well, I think that if you peel back your onion a little bit here,
Yeah.
then the second question is, the obvious answer is what it is. It's a medical student thing, but then you ask yourself, where is the accelerated rhythm coming from? And is there a baseline left bundle or not? So,
Pre-TAVR was
so
their
is it an
baseline.
accelerated junctional rhythm, or is it an accelerated fascicular rhythm, or is it an accelerated? I mean, it's an accelerated rhythm. So
Yeah.
the question is it accelerated fascicular, His, or ventricular? And I'm not sure what the answer is, but it's a nice left bundle-ish. So I would suspect that the patient has a pre-existing left bundle of some kind, and this is a
Well, TAVR could be new. Could be new left bundle.
Pre-existing.
Pre-existing, okay. Yeah, pre-existing left bundle. I don't know, I thought it was just an accelerated,
well, it's accelerated rhythm.
I thought it was VT.
The question is, where is it coming from? And if you know that the morphology is pretty good left bundle.
Yeah.
So it's not going to be ventricular.
The concern that the team had was that there was a problem with AV conduction.
We don't know that. I think it's fair to say that
don't know.
you can't evaluate it from this. I think there are two ways to manage the patient. One way would be to do a conduction study, although I don't think it would be necessary. I would say, well, based on the algorithm, the patient would be discharged home with a 30-day monitor.
And that's what happened. What we were showing here is that there's a competition between an AIVR and a sinus rhythm, and that there was no actual evidence of any change in the PR interval or the QRS width post a TAVR, and the patient went home with the monitor and did fine. So it was just a competition of
what would you do at the
AIVR and the sinus
bedside?
rhythm.
Aside
Have the
from
patient walk and
have the patient walk or do something, or
But it is a nice tracing.
Yeah, it's cool tracing.
Nice tracing.
Yeah, it's very nice tracing.
if you had the
Appreciate
patient
bringing it.
walk, if they could do that or accelerate the rate a little bit, what would you expect? If it was
the sinus rhythm would take over.
the sinus rhythm would take
which is
over,
what
and you'd
happened.
see that they got a baseline left bundle like they did before.
It looks like group meeting. So it'd be nice, next time we do this, we'll have them show the follow-up, like here's the baseline EKG.
Yeah.
Here's with walking, just to prove.
Well, I was happy that we got 5 or 6 people to give us tracings, frankly. Last time we did this, no one gave us anything. But just, I promised I'd move along. So next one, just because
Tiffany.
we promised Sheeta we'd move along, so we have to move along. Who's the next one, Tiffany? Tiffany. Thank you, Tiffany. Show us your tracing.
This is great. Another nice group meeting thing.
Group meeting.
Dr. Ellen Bogan and I shared a similar slide. This was a 90-year-old patient post-op, and this was a consult on general cardiology consults. The consult was for
90-year-old?
Yeah.
Post-op from what?
From what kind of
colon
operation?
resection, colon cancer. The consult was for AFib.
Well, it is an AFib. I was wondering why you're showing this to us. So the consult was for AFib because someone did not know how to read an ECG? Is that what you're saying? Okay.
Well,
It's Winky Bach.
Yeah.
I don't know. Am I missing something? I thought it was Winky Bach.
I thought this was more like an exercise in picking out the P waves.
Exactly, that's what it is. That's what you're trying to do. That's what these guys are doing. They think they've already got it, so they want one step ahead of you. But your step would be, where are the P waves?
He's making fun of us, yes. It's not AFib.
Agreed. And then the next slide shows the baseline rhythm, and you can kind of see that there are some maybe P waves hanging out in the T
Hold on, I'll
wave.
help you out. This thing is marked.
But my other question was, it seemed that in the inferior leads, the P wave axis was
Wait,
more.
how are you moving this thing? Wait.
Go back to the tracing and keep it simple, huh?
No. What are you doing? I had you. Why you're on a whole different
Giving us a
thing.
seizure there.
Keep on going back. Keep on going back. More.
Keep going.
Right.
That's it.
There.
So
Yeah.
is this actually sinus? The P wave axis in 2-3 AVF seemed
Here,
inverted.
and then I had a little trouble with this because this looked like almost like a PAC. The P waves are infantile, so it was hard to.
Yeah.
I had to use my little magnifying glass, but clearly it's a P wave there, and then there's a P wave here, and I tried to measure them going across, and I had a little trouble here, but it was a Winky box sequence, and it looked like it was going along, but the P waves weren't all that good.
They're hard to see.
They were just hard.
Matt, could you throw it over to my computer for 1 second?
What, George?
But they're
Just one
on
quick.
time.
Okay,
They're smack on time.
Yeah, they're on time.
And
Is that mine?
it is interesting.
All right, so what happened to my calipers?
Let me just say something.
You're right,
there.
though. It's
Thanks,
not
guys.
AFib.
For what I do without
Agreed.
you.
It
I mean,
is
that's great.
interesting.
It was in.
So here's the way horse's ass approach. So I look at this and I see a candidate right here. So what am I going to do with that? I'm going to get there.
Find Pixel 6 in the App Store. Like 20 others.
I'm gonna,
Couldn't find.
all right, then I'm gonna move this over here. And what do I see here? I see my candidate P waves, all right? Then I go like this, and I put one guy over here, the next guy over my next candidate P wave. Oh, come on. That's, I'm not even hungover, I just can't do this. Oh, there it is. All right, then I see the other guy in the middle, and you can just keep on walking. So there's a P wave that's not getting through. It's either getting through or it's a long PR interval, and then the next one, that one's not conducted. So that's a junctional escape with a P wave, and then it starts again. So it's a high-grade AV block, but it's an atrial rhythm. So I just wanted to go through how you're gonna, it's a P wave exercise, you're absolutely right. I mean, these guys are jumping ahead because they see it, but you and I have to look for it, all right? And it's much easier if you just take this and you enlarge it, put your calipers on it, and then you see the P waves. Why is this a P wave? It's not over here, is it? I mean, the QRS is changing. All of a sudden, you'd have a delta wave there, you see? It's a P wave, all right? So, sorry, I'm finished.
Yeah.
That's okay. I apologize. It's just that I promised Medtronic we wouldn't spend 30 minutes on this section, so I'm just trying to answer the questions. So it's Winky Bach post-op. So I assume the patient did fine? Yeah.
Tiffany.
Thank you, though, for bringing it.
There's a paper by Gautam Kalahasti 15, 20 years ago. About 5% of EKGs misread as AFib are not AFib. There are a variety of things. This is one of them. You should look it up. Gautam Kalahasti, I wrote it, I think, with Frank Bogan, looked at thousands of EKGs that were read as AFib and went back and looked at him. You'd be surprised at how many are misread as AFib and are something else like this.
Yeah.
Just look it up.
Those two-foot tachycardias are often misread as AFib.
Yes, absolutely.
All the time, exactly. That patient was sent to me as AFib that I showed the other day. Okay, great. Who's our next? George? Where you at, George?
Good morning.
Oh, George, hi. So let's get yours up there.
All right.
So I got to tell you, unless you're sandbagging me, I thought this was sinus.
Yeah, can we?
Am I wrong? This is like sinus to me.
Yeah, I don't like this one. This is why I turned in two. Can we go? There we go. Let's do
So
this.
is that not sinus?
I have to be honest with you. I looked at that one.
Hold on. Is that his EKG?
Yeah.
Those are two completely unrelated patients.
Oh, for Christ's sakes.
Yeah.
I'm looking at these.
He's a
two,
pretty tricky guy, huh?
Well, yeah, because I looked at this and I said, okay, and then I looked at ECG number 2.
But that's a rule violation, huh?
And I said, I don't get it. I mean, one's wide, one's narrow. What the hell? How did this happen? So I couldn't put this together. Now I know why, because they're two separate patients.
Okay, George, go to your second one, man.
ECG number 2 with the patient number 2. Yes,
You'd
my
kill us
apologies
if we
for the
did that.
first
But
one.
go ahead.
I hope you didn't use too many.
So this is the one you want us to look at?
Yes, please.
All right.
This is a.
So we have a basic rule up here. Anything paced, I kick to the right.
Okay.
I kick to the far right.
Go ahead, Ken.
Electrocardiographically. All right, so.
But you go ahead, give us your stem.
The stem is this is a 55-year-old woman with tricuspid atresia, and she had a surgically placed atrial pacing lead, and she's admitted now to undergo a right heart cath. I think there'd been a recent heart failure exacerbation, but in any case, this is a pre-procedural EKG. And I'll tell you that she's set to AAI.
AAI at 70, it looks like. So I'm glad you said that, because before you told me that, I thought we only see a single type of spike, and the spike sometimes is near the P waves and sometimes is near the R wave. So the first thing I thought about, could it be a lead that's coming back and forth across the tricuspid valve, sometimes sensing A, sometimes sensing V. First of all, but this electrocardiogram, so you see spikes, they occur at a regular rate, they seem to be unperturbed by the electrocardiogram. And it's not clear to me that they ever capture. So looking at this.
You don't think the third one captures, Ken?
Yeah, I thought the third one captured.
Well, You have to use your calipers. I'm not sure, but.
Oh, really? Looks like it brought in, don't you think?
First of all, let's look at the QRSs. They look pretty close.
How about the
No,
next one?
maybe.
I thought that one captured. No, George, didn't you think that?
I thought it looked like a catcher, but I
Okay.
mean, Ken's the boss.
Yeah,
So,
it's your call, again.
yeah, I have to look at it again with my calipers. If it does, but it does suggest to me that there's some issue with the lead in terms of the signals being sensed, in terms of the capture. I wonder if they put it very close to the tricuspid annulus. And so sometimes A, sometimes V. I would, this is an EKG, the thing, I'd want the EKG and the simultaneous marker channel so I know what the pacemaker thinks it's doing and what the pacemaker senses.
Is that what this thing is?
I have it, yeah.
So-
But that doesn't,
just wait a
that
sec.
doesn't, yeah, before.
Look at V4. I think V4 is helpful, huh? You see, if you assume that that's a paced A, then you have a QRS, then there's some guy sitting in the middle there that's positive, right? And you don't see that positivity of the repole when it's not paced, right?
Okay.
So that looks like a P wave. So then that looks like that P wave is not being sensed for me.
Well, so I don't see any change in the QRS. So I don't think it's doing anything in the ventricle, okay?
Yeah.
And now I'll focus on the P waves, okay? And they're not easily seen in every single lead. But I'm not really convinced it's doing much of anything to the P waves. So I don't think it's doing anything. I worry. So then I'm going to look at this. I haven't looked at it yet, but I don't think it's sensing or pacing the atrium.
You know, Ken, you really don't. I measured these last night. Had all intention of you discussing it, but I did measure it last night, and I could swear this is coming in. That this captured here, and I thought there was one other one, but certainly I thought, George, did you not think this one?
I did. I looked at lead 1, 2, and 3, and I was pretty convinced that that third one was sucking the QRS in a
I
bit.
thought so.
And
thought it
and the
captured.
P wave morphology changed. So we can argue about whether it captured. It's surely not sensing, huh? In
Right.
V4, it's not sensing.
So, yeah, it's clearly not sensing, and we can argue about whether it captures. I don't think it does, okay?
Okay.
If it should capture, it should move the QRS in. That's how you would tell.
Yeah, but that is moved in.
I didn't
think
measure
so?
it moved in, but maybe
Okay.
you can do it with your pixel sticks.
Okay, I
So
did it with
would
my
say
pixel sticks, and Ken
The
is
easiest
right.
thing to do would be to pace AOO at 110 beats a minute and do a pacing threshold, and then you know for sure.
I think Ken is right. It does not move it visibly on the pixel
I didn't
stick.
think so.
And my resolution is probably 20 milliseconds, Eric. I don't know what yours is.
Well, then,
didn't see it moving.
then I'm incorrect.
So it's
I
atrial lead
guess I
failure.
thought, okay, on the taper blown up here, yeah, it looks like
So
it
it's
does.
a typical.
So it doesn't do either one then,
Yeah.
right?
So it's a typical story, atrial epicardial lead failure. So the options would be to put a lead in the coronary sinus and do some sort of pacing. If the patient actually needs it, right now they look like, why do they need pacing?
Right, exactly. So she did need it at other times later, and I'm glad there was consensus that there was under sensing, but and so the purpose of the electrogram that I included on the next slide, I think, could help maybe answer the question of pacing, because even though I didn't see the QRS pulled in, I wonder when you look at this electrogram if that helps you comment on whether or not there's pacing. I don't have the one that proved
The
under
electrogram
sensing.
can't tell you that, right? I mean, it tells you it's near the annulus, right? Because that is a far field R wave. So if they put
Right.
the lead
Okay.
very superior, you wouldn't see a far field R wave.
And I think there's mislabeling, by the way, on the electrogram.
Well,
This
of
is an
course,
atrial-
it's typical.
Yeah.
We don't know where they program, but that's how the market channel reads. It thinks it's capturing because it has a pace spike, but there's an electrogram after that.
Yes.
And if it really is on the atrium, so want to know an electrogram without any pacing, right? just should, go to sensing and record the electrogram, and then see if it's any different during pacing. When you have electrograms this tiny, I mean, it is tiny.
But it's also reliably coupled with the spike.
Right, so it
at the
thinks
same
it's
time.
pacing, but I don't see it on the
Okay.
thing here. And so it'd be easy just to do a threshold check.
Yeah. Okay.
And did you do that?
Yes. So we did, and so it was determined that she was pacing. They did not have. Well, no, I'm sorry. There was failure to capture.
Right.
And there was under sensing. So.
And there was what?
It was under sensing.
Right,
So,
because the signal is so small.
Yeah. So they just increased decreased the sensitivity. Yeah.
And were they able to capture at a higher output?
Yes.
So they were able to reprogram the pacemaker. Not uncommon with epicardial leads to have late rises in threshold.
Do they usually go back down, or what do they?
No, they just end up chronically elevated. And,
What are you going to do at the gen change?
So
Change the lead? I mean,
right, probably it depends if it's an elderly patient. It depends how much it eats up the battery. The newer pulse generators have much more efficient circuits. So even the same size battery tends to last longer because the chips are smaller and they take less energy. So yeah, I think.
So you would just leave it alone right now?
Yeah, they program the output up.
Do you ever capture if you put the output up too much, will you capture the ventricle there?
I doubt it.
Far enough away, you would not capture because you can see the V on there.
Yeah.
I don't know, so I assume you didn't.
Everything
right?
is tiny here, and I think it's just some fibrosis around the lead.
Nice case, thanks. You shouldn't have shown us the other tracing.
Yeah.
Why did you show us? I'm just curious.
There was a reason for it. The problem is it was also I think the rhythm strip on the bottom of it actually had more information. I honestly, I can't.
Yeah, but it was cut off.
Exactly, and it shouldn't have been. I don't know why it was cut off.
I read that last night. It was after the Duke game. I was very happy. I'm sitting there and relaxed, and I went through the tracings, and I said, what the hell is this? Sinus rhythm, and now it's paced, and it's like different QRSs. I thought I must be smoking something, you know?
It may be no consolation, but when I looked at my scent basket anticipating this, I said the same thing to myself. I had a little memory gap there. But
is that unipolar pacing or bipolar pacing?
Oh, it was...
pretty big spike, huh?
Yeah, that was kind of
unipolar?
It had to be unipolar based on
unipolar pacing.
spike.
So that's pretty important. I try to get, when I was doing that, they no longer listen to me very much anymore. You're yesterday's man. But I tried to get everybody unipolar pacing, because you avoid all this confusion from the periphery when I don't see the spikes. And there's no downside to unipolar pacing.
So
there's some theoretical considerations, but.
So if you wanted just one last thing, and then I'll sit down, Eric. So there's one thing you could have done, which would have been like, oh my gosh, this proves it. You could have programmed the pacemaker to AAT, that's triggered mode. And every time it senses a P wave, it will put a pacing spike in that triggered mode. That's how you can check for sensing in patients who are not pacemaker dependent. So you could show us a 12-lead EKG, and we would see the spikes, unipolar spikes just marching through. But triggered mode is a way to check for sensing. So that would have been the coup de grace.
Cool. That's a good, really
I
good
don't
tip,
think I've ever
Ken.
done that.
I like that.
They obviously can't be pacemaker dependent. So,
correct.
So then you just put it in AAT?
Mm-hmm.
I don't think I've ever done that. That's very cool.
Well, I actually had a tracing we didn't get to, which I was going to show you, which was a patient who had AFib and was programmed, had a bi-V pacemaker, was programmed VVI at 60, was an AFib irregular between 70 and 100, but he was programmed to bi-V trigger. So he kept on putting spikes on his QRS. And so I handed me the EKG, and I said, it was irregular with irregular spikes. So what the hell is going on here? There must be an algorithm. Let me find out. So You know, it wasn't even in the little printout I got. I was like, hey, come on, did you put on triggered mode or what? And they were like, oh yeah, we did, sorry.
Yes.
Dr. Alan Bogan,
Yeah.
with the AAT mode, do you need to adjust the sensitivity?
Sure, well, you don't need to. You're testing to see whether it's sensing the way it's programmed. So AAT.
Got it. So whatever the sensitivity is
Right,
already
it'll
set
be
to,
at that
that's the only way.
sensitivity. Yeah, yeah.
So then every time so it should fire every time it sees
Yeah.
an atrial.
Right.
It'll fire in the V then.
It'll fire, it's just a single chamber pacemaker.
Oh, single chamber pacemaker, so it'll fire
Yeah,
in the every
yeah,
time. it
wherever
sees
you
it.
put it.
I got it. All right, so I promised Ashita did you have one more question? Go ahead.
I have the next tracing.
Yeah, we're gonna have to put it off. I'm sorry. No, we'll do it after break. I've got to give people a chance to check out if you have to, and then come back. So 15 minutes, Ashita. All right, and then we'll do yours before and when we come back.
Sounds good. Thanks.
Good cases.
Yeah, they're very good case.
So I saw your email about Josephson. Yeah.
Before you leave, could I please collect your surveys? These yellow forms, please. I just need to get these before you leave. Thank you. Thank you, thank you.
Okay, so I'll tell you what, George, we have, I promised that I would try to get everybody out here as close to 11 to 10 after, because there's flights and all the typical things on Sunday. Yeah, so let's try 11. What we have to do to end this is two things. We have one more unknown that was given to us. I mean, I must tell you, it was just thrown to me, so I really haven't had a chance to look at it. So maybe we can shorten it. You can show us the thing. We can opine quickly. But then I promised everybody I'd go through the quiz. So I definitely want to do that.
I'm over here. I'm glad you. Sorry, go ahead.
Just one second. So, but just because things at the end always get hustle bustle, I just want to, one more time, Ken's not here, but I assume he's coming back. Thank Ken and George. The three of us put this together. I haven't had so much fun in a long time. I mean, it's really, really a learning experience for me to work. I mean, I mean, we're all Dukies. We've known each other for years, and to learn from my two colleagues and to have fun with my two colleagues has been wonderful. So I have a personal thank you to both George and to Ken, very much so. Thank you, guys. Again, you know, years ago, we got into this whole thing about what's industry have to do with education. I mean, we went through all kinds of ups and downs with that. And I think that the bottom line is, as you go through your careers, understand that there's no evil giant out there called industry. The only evil is if you do incorrect, unethical things. So I would defy anybody. You've been through two full days, if you think of it, you know, 16 hours almost of teaching. And I defy anybody in any society to tell me that there was bias in what you got versus going to some CME course, right? So the point is, if you do it right, it's pure education. There's no sales job, there's none of that. And I just can't thank Medtronic enough for giving us really the opportunity to present pure education. So thank you very much. And after that, I'm going to turn it over to the young man who's going to give us a case that he just gave us.
So I'm glad that you didn't get to look through it because I put the answers within the slides.
So I just thought this was by Gemini. Is there any more to it?
So yeah, this was, the STEM is that there's no STEM. This was given to the cardiology fellows at their weekly EKG conference.
The STEM, wait, the STEM is there's no STEM? Is that what you said?
It's just a tracing that is how I was first given this tracing. And I thought there were a lot of subtleties that we could pick through.
So, I don't know. I just took a quick look at it, so it's probably not good because, but I mean, it's you know, it's group beating, and again, I have old eyes. I was having a hard time, but I thought I saw a P wave in front of the more narrow one of the two. They're both wideish, right? Where this thing is not working. Yeah, I thought there were P waves. Yeah, that's what I thought, George. I thought that was a P wave there. And that would mean, for me, I just thought it was sinus with PVCs by Gemini, but it may be too simple.
PR, the fourth week from the interval, and the PR looks like it's shortening. Right? So now we have a problem, and I think it goes up this week.
Oh, yeah, at the end, right. I didn't look, like I said, I just picked it up, so.
But it looks like there's something else, like an accelerated junctional rhythm or something, and PVC's coupled to the whatever it is, the accelerated rhythm.
Yeah, I didn't measure, are they coupled? I mean, I eyeballed a couple, but are they actually coupled?
They look like they're fixed
So,
coupled.
so they're fixed to the beat in front of them, right?
Yeah.
So they're fixed there, and the wider beat to me seems like it's coming from the ventricle. And you're right, George. I mean, I thought that was a sinus there, but I didn't track it straight through. I just got this. But actually, you're right. It looks like the P waves are not connected. So maybe it's a junctional rhythm with ventricular bigeminy or something like that.
And he's right that there's more to it than meets the eye, of course.
Of course, yeah. But I mean, that's just my first glance.
Yeah,
without-
and that was my initial impression too. But from kind of going from a top down anatomical approach, the atrial rhythm. So it's not sinus, and it is a little dissociated. If you look at V1, you can see some candidate P waves.
V1, you said? I'm sorry.
In V1, correct.
V1. Yeah, but like George said on the rhythm strip, isn't this a P wave here or no?
So my interpretation, and it marches through, is that those are flutter waves. I didn't include an illustration. I didn't have time to throw
That's
in
a flutter
anywhere.
wave?
It's marched out. So if you caliperize it, start to finish, the cycle length is 200 something milliseconds.
So I'm looking up here now. It's a little blown up. Okay, this is a little better than my sheet. So you're sort of saying here and here? Is that what you're saying?
The two negative deflections.
Well, hold
in
on.
V1.
Take a look at what I'm pointing at here. Just tell me, because on here I was having a hard time reading it. You saying maybe here?
Correct.
And here? So that's what you're
Correct.
saying, it's flutter. Okay.
Yep.
Fair enough.
I buy that.
Yeah, I'll buy that too. Okay.
And then, so I wasn't sure what the AV conduction was, whether this was accelerated or something else. And in V3, you have the clearest evidence of pacing spikes.
Okay.
And I saw that there. I didn't know if it was artifact because I only saw it once.
Yeah, and then
Right.
Coupled PVCs, as you guys had mentioned. And so that, I think that was,
That's unusual to have that be the only, you think V4 also maybe? I see what you're saying. So you think so the first one's just a pacing spike.
yes. And then the second one
So you have
is
flutter
possibly a
with heart
trigger
block and
PVC.
pacing spike and a PVC.
Yep. And so a
Okay.
lot of us kind of went through this. A lot of us fellows, we showed this to some of our faculty, and this was our consensus about this tracing.
Okay.
And so then afterwards, we were given the medical record number, so we dug into the chart a little bit. And then I think the next slide gives.
Can you move
little
that along,
stem, I
Matt?
think.
Or maybe I can. This?
My next slide is pacing.
Back
yeah.
one.
Is this the correct one?
Back one. So 81-year-old gentleman, sick sinus syndrome with a dual chamber pacemaker, ischemic cardiomyopathy, severe MR, just had CABG and MVR, and this EKG was on post-op day 3. And so my impression was possibly post-op valvular flutter, maybe not, but some sort of flutter, and then with VVI pacing and PVCs.
Fair enough.
And then the next several slides are just a sampling of various EKGs over the pre and post period.
So, so it looks like it's coupled to the P wave there, no?
Yeah, so this was, pre-procedure. This looks like sinus with ventricular pacing.
So does this person have heart block? Is that why you're pacing? You
I
don't
don't
usually
remember for
force
sure.
pace, huh?
Yeah, I'm not 100% certain.
Ken, what do you think? I mean, in other words, why would you want to force pace the ventricle post-operatively? Oh, pre-operative.
This is pre-op, correct?
Oh, so this patient has an underlying, well, wait, it's not based on your ECG that you gave us, right? Oh, that's post-op. I'm sorry, they're all jumbled in my thing here. Apologize.
Pre-op EKG,
Here's
heart
the-
waves, pretty prominent. Just sort of unusual. This is a dual chamber, not a.
That's what was recorded in the chart.
It just looks like it's tracking.
Yeah, it looks
No,
like
I
it's
know-
tracking.
I know that, but I'm just talking about QRS morphology.
Yeah, so that was, the QRS
Atypical.
morphology was a little
Okay.
funny, but it was, and that gave me some pause when I was looking at the original EKG, what type of pacing is it? Was it an epicardial lead or was this pacing from the patient's own device?
Okay, so assuming if you're pacing, that there's, you could be just fixed it at the interval in your pacing, or is it really a person who has complete heart block?
Yeah, that I'm not 100%.
Because that would help with the rest of the tracings if we know you're going in with heart block or not, right? Okay, so this is what we have here. So they have a next tracing here?
Yeah, there are a few more. So
POD2, okay.
so different QRS morphology,
Right bundle, yeah.
intermittent pacing.
The fourth beat from the end is a little interesting. First of all, it's a P-wave search exercise too, huh? So you'd very carefully look for P-waves and try to sort out who's married to whom. The first part's obviously some type of intrinsic rhythm that's probably related to P-waves once you start to measure them. The fourth beat from the end is interesting. Is it failure to sense? The fourth beat from the end, that, you know, and look at the bottom.
Fourth beat from the end.
Fourth beat from the end here.
Yep.
A lead
Looks
two,
like it.
two rhythm stripped. Is it failure to sense? Yes or no?
Looks that way, yes.
Ken?
I think so. It could be pseudo. If there's a right bundle, it may not sense to the
Late
terminal
sensing,
part of
probably
the
late
QRS.
sensing.
What kind of operation?
It was cabbage MVR.
Probably a fubart atrium, yeah.
Yeah.
So wait a second. So you go in then with permanent pacemaker working fine, right? Then 2 days post-op, it's not working?
So this was one of those unknown things to me. These EKGs were from like 10, 15 years ago, and the records were a little hard to find in our clinical archive. So
So that pacing one wasn't necessarily 2 days before the operation?
I don't know the exact timing. I'd have to go back and look at the dates on them.
Let me ask you differently. Was there any indication that it was pacemaker malfunction pre-op?
No.
Okay.
Not that I'm aware of.
Okay. Now, either it's like Ken said, I mean, it still was sensing before. Right. Okay, so, all right, that's a problem, or it could be a problem, right?
Could be.
And prior to the initial,
Is that day 3?
this is day 3, prior to the initial ECG, which is the initial one?
The first one that I put up.
Your first one you put up, okay. Okay.
Some of these are paced, right? So if I look at V3, V1, 2, 3, the third cycle, the last one in those precordial leads, that looks like a paced one, a little spike. And then I track it down to the bottom in lead 2, so now I know what the paced one looks like. It's these guys, right? So that's intrinsic.
Yeah, but can I ask you something, George? If it's I see the spike you're looking at, but if it's paced, it's certainly not pace morphology in V1, is it?
Well, it could be
pseudo capture or something.
Fused.
Yeah, I don't know, because this is certainly not what the original one was. Remember?
I just saw a pacing spike anyway.
No, I see what you're saying. I guess my concern is we saw that original one with the full paced beat. That isn't what we're seeing here, right? So either something's conducting. I mean, it doesn't seem like it's paced, or if it's paced, it's a pseudo fusion or something like that, right? Is that the right term? Yep.
Ken, is there?
I always feel good when he says yes.
Can you think, Ken, any reason why we can't program all ventricular pacing unipolar?
Oh, why we can't program all ventricular?
Unipolar pacing.
Unipolar. He doesn't care about malsense.
Not on pacemakers.
How about a defibrillator?
You can't program unipolar on a defibrillator.
You can't program unipolar pacing?
Correct. On a defibrillator.
On the Brady part, huh?
Correct, yeah.
Okay, then I stand corrected. But for a pacemaker, it would really help if we saw nice big spikes, wouldn't it?
Yeah.
It would help a lot. So this again becomes a P-wave searching exercise and trying to marry the two together to see if they're linked in any sensible way that you can think of.
Yeah. So this one for me was basically a baseline before that initial EKG where there's all sorts of funky stuff going on.
Right. Here there's pacing, but no PVCs.
Yes.
Is that the point?
Yes.
Yeah, but I guess I may be stuck on something I shouldn't be stuck on, but I mean, you presented tracing that shows AV capture, clear cut. We know the morphology of the captured things. My question initially was, do you really need pacing? I wasn't sure. And now we have a tracing where you're not really capturing anything, right? So is it because you didn't need it to begin with? You got a different rhythm? This is below the, I mean, I don't know, right? I need a little more, for me personally, I'd like a little more information. But anyway, since we don't have an hour, you're going to show us the next one, right?
Yep, and this was the initial one again.
Yeah.
just to kind of compare and contrast.
And then you're going to go to this one.
Yeah, so
That's no fun.
More ectopy, similar. It kind of starts with that QRS that we thought was paced, and then just a lot of triggered activity and coupled PVCs afterwards.
Why are they triggered?
And some
Where do you get triggered from?
For me, that's just thinking through it mechanistically. They're coupled after each QRS for the PVC.
He's not talking mechanistically, he's just.
Oh, you're not talking like triggered activity?
No, I was.
Oh, you were?
The PVCs, I thought, I might be incorrect about this, but I see that fixed coupling interval and
That doesn't make it triggered.
okay.
Did you ever hear of reentry?
True. Yeah, that's
Is it
true.
fixed coupling with reentry? Triggered is a very specific mechanism that has to be worked out. You can't just say it's triggered. I mean, in fact, I searched for triggered in the lab for years after Mike Rosen presented his things. I couldn't find one damn case. If you follow the rules of triggered with faster pacing and you shorten your post, I mean, all the rules of triggered activity, I don't mean EADs, DADs. I look for it. I'm just telling you, I looked for it for a long time. I don't know if you guys did, George or Ken, and I just, I couldn't reproduce the basic science. I mean, I'm not saying it does.
Well, the basic science is very specific for specific
the rules,
preparation. And
right? How you pace faster, you bring it in earlier. They have all these rules, and I looked for it like crazy in the lab. So I would say if you want to say things are related and things like that, but I don't know that you can put a mechanism on it. I think that's what we're saying.
But it's very disturbing, this one, because it kind of looks like an idiopathic VF type of pattern with very early R on T, right? So you see that in ischemia, you see that in idiopathic VF, you know, the rapid, Aisa Gare talked about, you know, idiopathic VF with very Purkinje sources and stuff like that. So this is a very concerning R on T type of phenomenon with an idiopathic VF type of. So you want to make sure that it's not ischemic if you can, when you do what you can do. And then you want to do something about that. So you, I don't know if pacing will help you get out of this. I don't think so. Maybe it's a medication thing. If you've got nothing you can correct ischemically, what do you think? What drug might be useful for this type of idiopathic VF-like?
And it looks like there's failure to sense here too. There's some spikes here.
Yeah, you see a spike that after a little run there.
For idiopathic VF, it's typically only responds to one drug, which is quinidine.
Quinidine. Okay, so then you'd have a hard time getting someone to give quinidine these days. It's, you know, we don't use quinidine, it's like poisoning somebody.
So I hate to be the bad guy here, but I have to shut this discussion down.
Well, summarize the case for us then with the.
Oh, I'm gonna let him summarize. Well, I don't know here. So what finally happened to the patient?
So he
gave amio or something?
Yeah, he got amio. He was very unstable hemodynamically, and he eventually improved. And you know,
You're
this
lucky
sort of
you didn't kill with the amio because it's not that type of. You want something to prolong the ERP, and I'm not sure that amio cut it, but I'm not sure it hurt him. But I think that probably the most important thing was getting his general shape better.
Absolutely.
And then he was okay. Pacemaker was working.
Yeah, I mean that part I don't remember all the details from this case. This I'd looked into a few months ago, but I do remember that when he got amio, there was, you know, within a few hours there was a significant improvement in his ectopy and you know, overall rhythm status.
Okay, let me just take the liberty of giving a little advice, because we're all teachers, we're all interested in this. If you present something like this, I would have picked 2 or 3 key slides out of this, right? Maybe a backup or 2 that we want to improve your point. That this one is a nice slide to feature, well, because it has a couple of good points. So you pick 1 or 2 or 3 slides that you're making a point out of it, and then you be prepared to tell us the answer from your backups. All right, so it was a little diffuse, and you know, it wasn't entirely clear what you were getting at with each of the slides. You did help us with it, but when you're teaching, pick a couple of key slides, well illustrated, have some backup and focus on them so that you have the answers rather than just bum, 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 bum. Because that takes a long time actually to go through each slide properly.
Yeah, I support with George. Sometimes George and I years ago did courses where we present a case. George is famous for showing one slide for his case and then get a nice discussion going. Some people feel you have to have 30 slides for a case. I deal with that all the time in the program I put on called Emerging Leaders. And they present, we get 15 or 16 that present. It's one of the courses I do at Medtronic. And they are young academics and they have 12-minute case and then like a 20-minute discussion. I get like 40 slides. Here we go again. And I write it back and say, when you get it down to 20 slides, I'll go over them with you. Oh, I love these slides. I said, well, you can take them to bed with you if you want, but you're not taking them to my course. So the point is, George will get up there, Mr. Laconic, and he'll say, here's my case. And he'll show one slide and we'll get a 20-minute discussion, because his point is, if you pick the right, if you have in your head, I want to teach these one or two things, then you don't need 30 slides, right? So there's nothing wrong with what you did, but George's point as you get older and start doing more presenting is to kind of say, what do I want to teach today with this, and just cut it down to what you want to teach. So you don't need, right? That's kind of what George's point is. So I'm going to switch to the quiz only because I made a promise that I would get people out of here and I don't want to break my promise. So let's go to the quiz, and then hopefully we can blitz through this, because if you look at the quiz, we will have answered almost everything during the course of 2 days with George and Ken.
You're going to look at the quiz now and say, gee, that's pretty easy.
Exactly. So I'm going to not ask you questions. I'm just going to tell you what you should have seen, because, and so you can just judge for yourselves. This is just a personal thing. So there's a rhythm strip with a PAC. The PAC has a long PR interval, and then you get, retrograde P waves. Tachycardia terminates with a P and no QRS, showing that almost surely AV node dependent. Starts with a long PR. The most likely diagnosis would be AV node reentry. Could I 100% rule out an accessory pathway? No, I'll tell you it was AV node reentry. So just to think about it. This should be straightforward to you now. Okay, this is what we talked about earlier. George had asked something about what would you do with somebody if you want to see how his Purkinje system's working. This is a patient who had, I was asked to see, and they showed me this, and they showed me a stress test, and I said, just put a pacemaker in. I can't remember, I did study him, take it back, because he was asymptomatic, and he did have Infrahisian disease. But again, coming back to the point, if you have higher grade AV block, or AV block as it is on a treadmill, as the rate increases, especially with a bundle, it's in his Purkinje system, period, with rare exceptions, okay? So you should all know that now. This is concealed conduction, right? So here's paced rhythm, VVI pacing. First sinus beat comes in after the pacing. Measure this PR interval versus this, and you'll see this one's prolonged. Alfred Pick saved his life, concealed conduction. Straightforward. You all get that? PR interval here is longer than here, okay? You have to explain it. The only reason why explanation would be you have a PVC in front of it. So this is like an RPPR, and then this is the normal PR. So this is concealed conduction. And that way, I went over that earlier. All right, so this is actually, I forgot I put this in there. Someone said, hey, it's in your quiz, Dr. P. I said, yeah, it shows you how much I remembered. So this is that lady who fell in her kitchen and hurt her hip and went to the ER, and they said, you didn't fall, you passed out. They saw this and they were ready to admit her for a pacemaker. Look at this, it's a 2-to-1 block, right? So 2-to-1 block, narrow QRS, probably AV node, who knows? Key issues here are, somebody pointed up, I think you pointed up yesterday, very, very savvy observation. Normal PR, a sudden prolongation PR, back towards the normal PR, not quite there, but almost. How does that happen? There's no physiology to explain that. PP's on time, it's not a vagal surge. You can't physiologically explain it, means something else is going on, okay? And then you see a junctional beat here, see that? Now, I figured all that out. I got to admit, I went to the cleaners on these two. I thought they were PVCs, and I got worried, okay? But I can tell you every single ectopy on here was a junctional beat with either a weird aberrancy or not. Here, I'll just show you I didn't show you. So in other words, I called this his extrasystoles causing a 2-to-1 block pattern, causing the PR prolongation. I had all that down. I thought, big deal. I mean, I had to study her because everyone wanted to put a pacemaker in her. George, I thought these were PVCs. I got to fess up. Every wide beat was a junctional with like HVs of 90, 100. So I went down the tubes on there. I initially said, I thought I was so clever on my ECG reading, you know, for posterity in the chart. And then I wish I could have gone back and erased the N PVCs part, but it's already in there. So I blew that, okay? But here you can see sinus, see that his extrasystole in there? Okay, next AH is long, okay, giving you the sudden prolongation of the PR because of concealed conduction. Here's a normal and here's a junctional manifest, see the his junctional, and then the next one will come down obviously with a long PR also. And all kinds of variations on a theme. I've got reams of figures from this patient, okay? But all those bizarre things, sadly, were good for her. We're all junctional prematures. So, I don't know. Ken, they look like PVCs. What can I tell you? All right, I blew that one. This is 2-to-1. You all know this one right now. 2-to-1 normal PR bundle. Where is it? In the his, below the his, in the AV node. Shout it out. Below the his, boom, boom, boom. See how expert you are now? Straightforward. Okay, dizzy sends in they always send in a strip when they're dizzy, you know? Doesn't it always, it's a pain in the ass. Okay, but if you're very careful, you can apply the George Klein rule, which I use always too, or just be real careful with your measurements. You just don't get this, you don't get two things this far together unless you're dealing with a rodent. Remember that. It's actually true, right? The ventricular ERP in mice is like 40 or 50 or 60 milliseconds. But as long as this isn't, and there are humans that are rodents, so I don't want to totally rule it out. But anyway, you can't get, right, George, this stuff? They're non-physiologic, yeah. We'll call them rodent-like from now on. That's our new term, rodent-like. Anyway, they're non-physiologic, and if you actually get really careful, put your calipers, you can kind of find a pattern in here. It just takes you a long time, but you know that's not physiologic. It's just noise, right? It's artifact, and you move on, even though they said they were dizzy. This is another one of those long RP, or as George likes to say, short PR tachycardias. You know, I don't know why you just always have to be George. Anyway, so is everything short PR? So if it's a slow fast, you'll give it the fact that it's a short PR, right? You okay with that? A short RP, rather?
Well, I don't care what you call it, but the trick is to relate who's the horse and who's the cart.
I know, I'm teasing you. Anyway, you can see a PVC here, and this goes back to one that Dr. Klein showed, remember? And I showed one also where there's a PVC, it terminates tachycardia. So it's a long RP, you got your differential, you know, boom, boom, boom. But if you actually measure this out, you'll see it occurs at a time that it's very late actually, and it terminates tachycardia right after the P wave is starting. So it's pretty much his synchronous. It terminates tachycardia, game, set, match. It is AVRT, exactly, accessory pathway mediated tachycardia. See how smart you are? Boom, boom, boom. I knew you'd get those. And here it is in the lab, just in case you were going to say, I don't believe you, Prostowski. Yeah, no, you go home, Prostowski showed us Tracy, but he never showed us a backup. I don't believe him. So you can't argue with this, right? Isn't this pretty? That's so nice, so clean. His right there, it's just perfect. Okay. And this is what? Well, go back to the George search for things, right? So if you look at this tracing, let's just take a V1, okay? So this is a wide that merges into a narrow. What are you supposed to measure then? RRs of the wide and the narrow, and what'd you come up with? Wide is slower than the narrow. Could be just coincident VT that went into an SVT. Could be, except how does it start? Go back to the GK method here. What about this little bugger? starts with a PAC, right? So you know the first one's SVT, you know the second one's SVT, you know that the wide is longer than the narrow is only one diagnosis. ORT, AVRT. It looks like did you train with Heim Wellens? ORT. That's a Heim Wellens thing.
Look at the very bottom where it transitions from wide to narrow.
Bless you.
You see that the first narrow is right on time, but it changes the cycle length.
I'm sorry, what?
Okay, sorry, Jim. It changes its cycle length after, so it goes from wide to narrow without exactly the same interval, and then the tachycardia cycle length changes. So that tells you that the left bundle is part of the circuit, whatever it is,
Right.
right?
So I'm gonna dig down. So where does the cycle length change? I'm gonna give you two choices. The cycle length change here to here or here to here? So I'll give you here, wide to narrow. Do you expect the cycle length change wide to narrow? Don't measure. Wide to narrow, is that the change in the cycle length? It's a second narrow. Why is that?
What shortens from left bundle to normal for the left half? The VA.
Correct. So that's common misconception. People will put their calipers on the wide to narrow and say it didn't change. And that's because, exactly what George said, when you go from a wide to a narrow, okay, so that changes the V to A here in the next one then, but this interval is still already part of the circuit, right? I mean, you've already committed that one, it's gonna be the same cycle length. The next one will shorten. To make life easier, just go over here somewhere. That's what I just look at it here and I look at it here and I call it a day. So AV reentry proved, all by an ECG. Very good, well done. This is your classic fooler. I'm not going to go into all the things. You've heard this from George a million times. It's a P wave sitting right here. It's a right bundle. It turns out when you wait a little longer in the strip, it becomes obvious. It's flutter with 2 to 1. Always be suspicious when you see this. You can try to find it. I mean, honestly, I couldn't be sure I found it anywhere else. But you know, if you just wait long enough or do a hold, if you have it like this in an office and you're not sure, just do a Holter. Someplace during the day, you're going to find the answer. The rate will slow down a little bit. You'll get block, right? And you'll say, oh, there it is. Or if you want to push on the carotid, you can do all that. But the point is, anytime you see this, be suspicious of flutter with 2 to 1. Sometimes it's really hard to be 100%, even though you can play around with it and think you see it. Just wait till you have an opening, as George said. Just opening, is that what you called it? Or gap, I forgot.
Hole.
Hole. Okay, wait till you have a hole in the tracing and life becomes easy. So this is flutter, okay, with 2 to 1 and other ratios.
The other little tip is that if you look at the individual with this tachycardia, you say to yourself, there's no way this person's going to have a sinus tach at 150.
That's also true. But I mean, you could argue, you know, someone could argue maybe it's AV node reentry or something. I don't know. Who knows? All right, trying to move along. Here's the sinus beat. And here's the tachycardia in this patient. I don't think I gave you anything else, if I'm remembering correctly, right? So basically, you had to look carefully, and you'll see there's AV dissociation. Without me going into it in detail, you have to look. And here in the lab, you can see that you can start tachycardia. You know, this goes down, and then you see tachycardia starts here with VA dissociation. This was one of these high septal tachycardias the patient had. Okay, so you can see, you have to look carefully. You can see dissociation. I can squinting here, but that's why I gave you a sinus to begin with. You can see this is. And you can also use the EKG rules, look at AVR. I mean, there's a lot of ways to figure it. There is AV dissociation if you look carefully. And then, okay, I put this in because none of us showed it. What is this? Pre-excited AFib, exactly. Pre-excited AFib, not non-sustained VT, okay? Is this patient at high risk for sudden death or not? Yes. Right.
AV nodal blocking drugs are not contraindicated. They're merely useless.
Don't put them down, though.
No,
Don't give 'em.
Yeah, that's fine what you're saying
Give
there.
them in Canada, but not in the
The
United
United States don't use them. If a patient dies, it's a lawsuit, and I'm not coming to help you because in every place in the world it says it's contraindicated. Don't give IV verapamil. You just can't do it.
Doesn't mean that I'm just arguing about the rationale. If somebody
Right.
says
I'm
to you
talking
that
about
the AV node releases the pathway, they don't get it
That's my last one.
because the AV node is watching the traffic go by.
I got you. All right, what's this?
Oh, this is a good one. We didn't show that. See?
Here's normal tracing. And this great thing, Sotalol initiation in the hospital. Good time. Sometimes you want to start it in the hospital. Oops. Oops. Torsade, right? All right. I think you guys did a great job. I tell you, like I said to someone in the offside, just chatting with you, this is really we've done these kinds of things for a number of years. You ought to be real proud of your progress so far. You guys, ladies and gentlemen, did a wonderful job. We thank you for your energy. We thank you for your participation. And I feel terrible about this next comment. Go Duke. Thank you all very much.
Before Dr. Ellenbogen leaves, could we please give a big hand to our faculty, Dr. Ellenbogen, Dr. Klein, Dr. Prostowski. Thank you, thank you. Thank you very much. So with that, I just need your surveys, please. A huge thank you to our AV and our logistics team, Marna and Sarah out there. And yes, thank you very much. So all I need is your yellow forms, and the buses that are taking you to O'Hare are out there already. We'll leave at 11:30. If you have a later flight, you're on your, just take Uber and give us the expense receipts. Anywhere midway, you'll take an Uber out front. And that's it. So hope to see you at our next course. Thank you for being here. Yes. Bye. Thank you.